to all. I heartily welcome all participants, physicians, other faculty members, colleagues, and practitioners, and others who have joined this virtual meeting from whichever place you have joined for this World Diabetes Day program. World Diabetes Day became an official United Nations Day in 2006 with the passage of United Nations resolution. It is marked every year on 14 November, the birthday of Sir Frederick Banting, who co-discovered insulin along with Charles Best in 1922. This year, 2020, theme being Nurse and the Diabetes, their supporting role. On this occasion of World Diabetes Day, though officially celebrated on 14th November every year, due to Deepavali festival on 14th, as all are busy in performing their pujas of the hospital, we have preponed by a day of one day. On this occasion, on behalf of MESAT, ACP India and API Gulbarga, I heartily welcome Dr. P.S. Shankar, Professor Emeritus, who needs no introduction. I also welcome Dr. Y.P. Munjal, the Doyen of API, who has held many top posts in API from Delhi and past president of API and so many other organizations, for accepting our invitation to be the guest of honor for today's inauguration. I also welcome Dr. Muruganathan, Governor ACP India chapter, for guest of honor to join the meeting. I welcome Dr. Shivraj Alsetti, President MESAT. Welcome Dr. Murugesh Pastapur, Chairman API and his team Gulbarga. And our guest faculty, Dr. Professor H.B. Chandalia, Director of Endocrinology and Diabetes and Metabolism, Jaslok Hospital, and senior most faculty of the country in diabetes from Mumbai. His schedule did not permit him to come to Gulbarga for our earlier invitation, but COVID-19 pandemic made him to join virtually this time. In this bad time of COVID era, when whole country and world is affected in difficult situation, I salute the COVID warriors and healthcare workers for rendering their services in spite of so many hurdles and sacrificing their lives in this bad time. I welcome our faculty, Professor V. Sheshaya, founder patron of DIPSI India from Chennai, a senior most faculty of diabetes in the country. I also welcome Dr. Ashok Das, Professor and HOD, Department of Endocrinology, Pondicherry, a well-known personality in the field of diabetes in the country. He has a special affectionate to Gulbarga, a close associate of Dr. P. S. Shankar and late Dr. Muralidhar S. Rao, but his schedule did not permit him to come to Gulbarga physically and deliver the lecture. I also welcome our own faculty, Dr. Anil Bansali, BC Roy Awardee, Professor and Head of the Department of Endocrinology, PJ Chandigarh. We invited him earlier, but he did not come, but he has sent his colleague, Dr. Pinaki, from his department. I also welcome Dr. A.H. Zargar, Chief Endocrinologist from Srinagar, has held many positions in the past, like he was the President Endocrine Society of India, Member Medical Council of India, Director of Sher-e-Kashmir Institute of Medical Science, and a great faculty of diabetes in the country. All the faculty, in spite of their busy schedule, readily accepted our invitation to join the meeting virtually. In fact, we are lucky enough to see all great personalities and luminaries and authorities in field of diabetes whose CV runs in pages. Let us not waste time in reading the CV. You can just type their name in Google. You will see pages and pages of their profile, which speaks how great personalities all are. Let us utilize their time by hearing and exchange of knowledge on topics of diabetes on this World Diabetes Day. I once again thank all the faculty for accepting our invitation and to join virtually amidst the festival season. I welcome one and all who have joined for this program. Now we will have a virtual lighting of lamp and a formal inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म
Now I request Dr. P.S. Shankar, our guest of honor, to address the gathering. Kindly unmute, sir. Unmute.
Wish you all a happy Diwali. Dr. Munjal, Dr. Seshaya, Dr. Ashok Das, Dr. Jargal, Dr. Chandalia, Dr. Bansali,
Yes.
and other faculty. Dr. Alshetty, Dr. Biradar, Dr. Murugesh, colleagues and friends. We have assembled here to hear from the top authorities of India on diabetes. I am very happy to meet Dr. Munjal, Dr. Seshaya, Dr. Das, and Chandalia after a long time, and they have all visited Kalburgi on earlier occasions. World Diabetes Day was created in 1991 by International Diabetes Federation and the World Health Organization in response to the growing concerns about the escalating health threat posed by diabetes. World Diabetes Day became an official United Nations Day in 2006. It is marked every year on 14 November, the birthday of Sir Frederick Banting, who co-discovered the insulin along with Charles Best in 1922. Since then, insulin has become an effective treatment against diabetes. Diabetes is a serious epidemic and lifestyle disease affecting millions over the world. 1 in 2 persons live with type 2 diabetes undiagnosed, and over 425 million people are affected by type 2 diabetes. Type 1 diabetes is not preventable but can be managed with insulin injections. The cost of daily monitoring, insulin injections, and ongoing treatments affect the finances of the families. The condition is causing emotional distress among people without access to diabetes education programs. In 2020, the World Diabetes Day campaign focuses on promoting the role of nurses in the prevention and management of diabetes with the theme, the nurse and the diabetes. Without the support of nurses, people living with diabetes can be at greater risk of developing complications. The aim of this day is to increase awareness of diabetes through the campaigns. It raises awareness of the impact of diabetes on society, encouraging early diagnosis and support those who are affected. Though diabetes is not reversible on getting it, one can live with it without compromising on the quality of life. It also raises the awareness on the ways to prevent the diabetes and delay the onset of the complications, and from healthy diet and the physical activity. It tries to prevent the complications, making them aware of the warning signs. It boosts the role of the family and the nurses in the health education. The day gives an opportunity to get tips on the food, exercise, and the lifestyle. The campaign is represented by a blue circle logo, which is the global symbol for diabetes awareness. It signifies the unity of the global diabetes community in response to the diabetic epidemic. We are eager to hear on insulin therapy and the preventive strategies in diabetes by the stalwarts. I am happy to inaugurate this program. Thank you very much.
Thank you, sir. Good evening, Dr. Munjal, sir. Now I request Dr. Y.P. Munjal to deliver his inaugural address. Kindly unmute, sir. Kindly unmute, sir. Unmute.
Dr. Munjal sir, kindly unmute and speak, sir. Munjal sir, can you hear me? Dr. Munjal?
Kindly unmute, sir. Unmute and speak, sir. There's an option mute, unmute.
I think
Asked to unmute. Either karo, hum hi karte.
Yeah, you can call him over the phone.
Okay, before he gets connected, I request Dr. Muruganathan to speak few words.
Oh, thank you, Dr. Sangrabdar. The COVID has done so many bad things, but one good thing it has done, so many of the stalwarts can be brought on the online. Where do I see our Chandilya, Dr. Munjal, Dr. Seshaya, Dr. Shankar, Ashok Kumar Das, Anil Bansali, so many people in one forum. And that is the one good thing, this our Jagar from the Kashmir. So Kashmir to Kanyakumari, now the online has connected. So now I used to call online is the lifeline now for us, especially for people like me. A day in, a day out, only we are in the online. So my wife was saying, you during Diwali also you are doing online. I said it is not online business, it's online education. And one thing about diabetes, Dr. Shankar has given elaborately about what World Diabetes Day all about, the nursing, the importance of nurse and all that. One thing I want to tell all the people, they have to do an awareness
Yes,
program
you
on
can see me on the
diabetes.
screen. Dr. Munjal is there.
They have to do an awareness program among the non-medical people.
Okay, thank you.
Especially,
You don't need to call. Yes, he'll directly start speaking once you allow him. Okay. अगली आपकी बारी होगी.
Yeah, during Diwali, one message we must give.
No, ठीक है.
Always exchange sweets. Exchange sweets. Exchange. You have to exchange. If you want to give somebody, give fruits, give nuts. Nuts nurture the heart. So don't have of exchanging sweets during Diwali and be the safe Diwali. For example, all of us are using sanitizer. 24 hours on and off we are using. With the sanitizer, if you fire crackers or if you light the lamp or even if you take Mangalarti, it is a dangerous thing because your hands will be burning. So don't use sanitizer before lighting the lamp. You should not fire crackers. Firecrackers, very, very important. You tell these messages to all your family, non-medical people. And only one point I would like to emphasize in diabetes. Whenever there is hypoglycemia, Jagar, Ashok Kumar Das, Siddha, Seshaya sir, Munjal sir, hypoglycemia, nobody takes ECG. Please take ECG during hypoglycemia. Even if they recover, you take ECG. There are changes in hypoglycemia, ECG changes. So there is no paper. What are ECG changes in hypoglycemia? Maybe Ashok Das and people like us, Jagat, can present a paper on ECG changes during hypoglycemia. With this, I request all of you to have a safe and happy Diwali. And thanks, Sangram brother, for bringing me and making me meet all the stalwarts in the country on diabetes. Thank you very much. Namaste. Good night.
Thank you, sir. Dr. Munjal is online. I request Dr. Munjal, sir, to deliver your inaugural address. Kindly unmute, sir.
Hello.
Yeah, just unmute and yeah, now it's unmuted. Let him speak.
हाँ ओके आप बात करो क्या है
Hello, sir. Can you hear, sir?
आप बोलो
Yeah, I can hear you. Can you hear me?
Yes, sir. Right,
Yeah,
right.
yeah, we are all
Please,
hearing.
please, please.
Yes,
Yeah,
sir.
please, sir. We are waiting for your speech.
We are able to listen, sir. Munjal bhai, you are able to listen. Please start.
Munjal sir, go ahead, sir.
Please go ahead, sir. Please go ahead.
Distinguished members of the diabetic faculty and delegates, we have very experienced stalwarts going to deliver on the prevention and management of diabetes. A point I would like to make out, that is that prevent diabetes, that is the best cost-effective method. If you treat diabetes effectively in the early part of diabetes, the chances of complications become very much less. But once complications occur, then it becomes an expensive disease. Coronary artery disease, renal failure, they all add up to the cost. Another important issue is, especially you find that people who suffer from complications, one of which very common complication is peripheral neuropathy, which leads on to, at times, amputation. The amputation is second only to traumatic amputation. Therefore, examination of feet is very, very important, as well as mandatory in patients of diabetes. In this era, on the occasion of the World Diabetes Day, it is a very important issue which has been taken by the Gulbarga branch, and Dr. Biradar has been able to collect as well as request to such big stalwarts like Dr. Charnalia, Dr. A.K. Das, Dr. Shishaya, to discuss this particular aspect of diabetes. Dr. Shankar has been able to very effectively delineate the history of so-called the World Diabetes Day, how it is celebrated, why it is celebrated, and it is a tribute to Banting that this particular day has been fixed for diabetes. I would like to apologize for having joined late, and I wish the deliberations a grand success, and especially compliment Dr. Biradar for having this particular theme on the occasion of the World Diabetes Day. With this, I have great pleasure in inaugurating the scientific program as well as be part of the deliberations this evening. I expect that Professor Das, who is going to talk on insulin, which was first discovered and put to clinical use in 1922, and it has stood the test of time. It prevents complications, and if you start it early, then the results are reasonably good. The new methods of treatment, especially SGLT2 inhibitors, have helped us not only to control diabetes, but also to prevent the progression of renal disease, hypertension, as well as heart disease. With these few words, I conclude, and before I conclude, I would like to apologize for the delay which I caused to the organizers for this program. Thank you very much. Happy
Thank you,
Diwali to everyone, and all the best for the coming year.
Thank you, sir. Our sincere regards. Thank you, sir.
Thank you, sir, for your kind words and to inaugurate our virtual meeting. Your words of wisdom are well taken, sir. Thank you so much. Now we move on to the scientific session. I request Dr. Professor Chandalia, sir, to deliver his talk on topic minimizing hypoglycemia in insulin therapy. I request all the audience to share the questions on the chat box. After this session, Dr. Chandalia will take questions with Dr. Ashok Das to moderate. Over to Dr. Chandalia, sir.
Thank you. Can I be heard, Dr. Biradar? Yeah.
Yes, sir.
Thank you. Thank you, Dr. Sangram Biradar. And my distinguished colleagues, Dr. Shankar and Dr. Yashpal Munjal, veterans of API, and my seniors, and my colleagues who are on the panel for today's presentations and discussion. Can I share the screen now? Can I start my slides? Yeah.
उसमें ही पढ़ी थी मैंने कल नहीं देखी थी.
Okay. So here you are. So my topic today is minimizing hypoglycemia with insulin therapy. When we consider insulin therapy, the only drawback which occurs, which we have to face all the time, is hypoglycemia. And if we develop strategies to manage hypoglycemia, you cannot eliminate hypoglycemia when you undertake insulin therapy, because this is a very, very potent and effective drug. But you have to learn to use it, and I'll give you some of the very important clinical tips as to how you can use it without producing and distressing hypoglycemia in large number of patients. So I'll be discussing, my topic will go through this, discussing the hypoglycemia incidence, dangers, why the hypoglycemia, what is the genesis of it, how do we minimize, and some of the special situations. So I'll go a little fast, but I'll make some good points for you very quickly. Hypoglycemia, of course, is the main problem occurring with sulfonylureas and insulin therapy, far more with these two than any other drugs. Many other drugs do not cause as much hypoglycemia as these two classes. And therefore, when you combine these two, be very careful. I'll allude to it later on also again as we go along. Important thing on this slide is showing that standard and intensive treatment. Whenever you intensify treatment and you want to reach a target which is difficult to achieve, you will face hypoglycemia. And all of the study like DCCT study, where type 1 are all treated with insulin, you see the standard treatment versus intensive is almost 3 times hypoglycemia. So when you intensify therapy, you have to be extremely careful how you do it without causing hypoglycemia. So I'll pass on this rapidly. So when you ask a lot of physicians that what is the barrier to your using insulin, they say it is hypoglycemia, most of them. If that barrier can be at least mitigated, that problem can be mitigated, you'll all feel confident in using insulin. So intensive therapy versus standard, there is difference. Remember that one accompaniment of recurrent hypoglycemia is the weight gain. And it is said that there is defensive eating being undertaken by patients to ward off hypoglycemia, and that produces higher weight gain in the intensive group versus the others. However, you must know, as we produced some data some time ago, published a paper where we showed that many patients gaining weight with insulin therapy really is because of the weight loss that occurred before instituting insulin therapy when the hyperglycemia was very bad. So at that time they lose weight, and often that weight comes back very fast as soon as you treat them. But you can exceed the weight gain, then there's the pre-treatment weight if you really use insulin in very large doses and cause a lot of hypoglycemia. The hypoglycemia is not my exact subject, but I must tell you that although we don't discuss very candidly the possibility, the severe hypoglycemic episode, several episodes, possibility of cognitive defect. We don't discuss that with any alacrity with our patients, but it is true. As Dr. Muruganathan was mentioning, EKG, you see during hypoglycemia, QTC can increase and potassium can go in the cells.
अरे आवाज ऑन नहीं करने चाहिए कर अलग आवाज हम कैसा कर नहीं बोले एक हम ऑप्शन रहेगा.
Can you ask the audience to mute, please? Yeah. Now, with hypoglycemia, you can also have a difficulty in having your baroreflexes intact and autonomic disturbances in diabetics. For example, under anesthesia, hypoglycemia can be very bad because the patient may not rally, the autonomic function is further impaired under anesthesia. Hypoglycemia produces these harmful radicals to the endothelial wall muscle, and now there are a lot of studies showing that recurrent hypoglycemia leads to more vascular disease. This is coming up in a big way. There are many papers in the recent literature that vascular complications increase with hypoglycemia. So I will again pass off this subject because I just wanted to allude to it. Now, why do you get hypoglycemia with insulin therapy? See, here you have in the green, you have the profile of a normal person, glucose profile during 24 hours. And then in the red and yellow is the diabetic. The red is the basal hyperglycemia, I see. And then there are peaks, prandial peaks. And when we treat a patient with insulin therapy, we address the issue of both basal problem, basal hyperglycemia and prandial hyperglycemia. And we have to understand this very well, this glucose profile and the normal insulin secretion profile in normal individuals. And we should mimic by the insulin at our command and coming very close to the normal physiology. Basal and prandial hyperglycemia, you see, very important. Basal is due to hepatic glucose production. And I want you to know that when you craft your prescription, I would not say even write your prescription. When you craft an insulin prescription, you must remember that almost half of the insulin should be basal. This is a common error in prescriptions, including when we reviewed our prescription about 5 years ago. We realized that in a very well-planned basal bolus therapy, my basal doses were 20-25%, minimum 40%, if not 50%, because as I tell you later on, it minimizes hypoglycemia, because hypoglycemia is far more common with prandial or quick-acting insulins than with basal, and the intensity of hypoglycemia is particularly frightening with short-acting insulins. Basal and bolus, we separate hyperglycemia as well as insulins, basal and bolus insulins. But remember, one overlaps the other. For example, a good basal insulin will also load the prandial sugar as well. So they overlap each other. And remember, a prandial insulin, which has slightly longer action like the human regular, will have interprandial effect as well. And by the same token, in the interprandial period, it will there is a possibility of hypoglycemia produced by this insulin. This is typical what is called biostatter studies, which done 3-4 decades ago when they were used for research purposes. And in type 1 diabetics, it was shown that again the half of the insulin requirement is due to basal purposes, other half is for prandial, and the maximum requirement is at breakfast, next is at dinner time, and least is at lunch. So these are some of the clues I'm giving you in order to craft a very good insulin prescription in a difficult patient, especially type 1 diabetic. And you see percentages here at breakfast and lunch and dinner time. At dinner time, lot of basal insulin. At breakfast time, lot of prandial or plain or regular insulin. This is a simple fact we often discuss, our diabetes educator discuss with patients. But remember that non-rotating sites and having lipohypertrophy and injecting through that site can produce a lot of variability of response. And once there is a variability, the adjustments are not appropriate, and you will therefore induce a lot of hypoglycemia. This is another very interesting aspect of hypoglycemia. You see that multiple doses is the key to avoiding hypoglycemia. Now this appears paradoxical to you, and you might think that patients don't accept multiple doses easily. But one who has suffered from hypoglycemia because of single dose or single injection of some mixtures will be grateful to you if you add 1 or 2 more doses, but avoid that hypoglycemia, frightening hypoglycemia that he or she went through and landed in the hospital. So multiple doses, some of these studies show that when you use multiple doses, basal bolus regime is almost the best. This is study comparing pre-meal with the basal bolus. You see, and in the end, you see a basal with 3 shots of regular, and you find there the targets achieved is much better. So three times a day. So don't hesitate to use multiple doses. There is inhibition in the treating physician's mind in using multiple doses, but that is one key to preventing hypoglycemia. Another interesting thing is that there is a difference between human regular insulin and the quick acting analogs. And now you have even very fast acting aspart also. So you have the insulins now at our command, which have tremendously improved properties. If you want very quick action, you have insulins which will act almost immediately, or in about 15 minutes will be like glucosine and aspart and Humalog, you see, and of course human regular will be slow to start, but it continues in the interplanetary period. So the difference is in the pharmacokinetics of these insulins you must understand, and pharmacodynamics, how they act in the body and the profile they produce. NPH is a basal insulin for poor people, but it is not appropriate in the current time, frankly, apart from when there are very serious cost considerations, because it has a lot of nocturnal hypoglycemia, and you cannot cover by single dose. It has to be at least 2 doses of NPH in a day, but that is a poor person's basal insulin. So when you use better insulins like Levemir, and subsequently we have Glargine, so I'm not going to go into details of these insulins because that is not my talk is not on those varieties of insulins. But remember that good insulins at our command, and what is good insulin? You see, the quick one, when you want it to act quickly, it should be as fast as possible and go off in about 2 hours. And the basal should, slowly go up, maintain a very steady concentration for 24 hours or even longer, so that it gives the patient some flexibility of injecting that basal 2 hours before or 2 hours after. So some of those insulins we use now offer this kind of advantages, and that I think you hear in many of the lectures which are focused on the insulins. So I'll not go into details of that. The variation in absorption and bioavailability of insulin are very, very are marked. And you must know that causes a lot of hypoglycemia, because same dose can produce the 3 different glucose profile. And that really, this is called the coefficient of variation of insulin action. Very well known, but not yet been addressed very, very frontally, not frontally. Side attacks are there. Regular insulin, remember, and short-acting insulins have less variability of response, but long-acting insulins have much more. Only thing is the newer basal insulins are slowly narrowing down this variation from day to day in the same individual with same diet and exercise, and those are like the degludec insulin or Glargine 300. Those are the best basal insulins we have available at the present time. and they come close to again 20%, but otherwise the regular insulins are short acting is less variability. So remember that when you're planning your insulin therapy. The variability of response goes very low with insulin pumps. So type 1, you may have to use pumps for the reason that the variability coefficient of variation comes to as low as 3%, while normally it is 20%, 50%, 20%. And we saw in longer acting insulins even 30, 40%. When you sensitize, another clue to giving successful insulin therapy without hypoglycemia is sensitize a type 2 diabetic patient to insulin. Without using a sensitizer, attempting successful insulin therapy in a type 2 diabetic is going to be very difficult. I don't remember many of my difficult type 2 who are being treated with insulin alone, even if it is 4 doses or even 5 doses sometimes. Sensitization is important. So this is another principle of treating people type 2 diabetes with insulin. But when you use a sensitizing agent, because insulin itself can produce hypoglycemia, and therefore you must use what you find here under the anti-hyperglycemic drug. I use this word which is not often used in the book, but these are the drugs which don't cause much hypoglycemia, but they lower the hyperglycemia and bring to you glycemic level. And these are the ones you should use, besides metformin being the one most important. Remember that the newer one, including the DPP-4, SGLT2, all of them by lowering hyperglycemia have a sensitizing effect. If you get hypoglycemia very distressing in your patient and you are attempting the A1C of 6.5, please revise your target. This patient is not the one, this target is not appropriate. You will have to revise the target in some of them. Very long-standing type 2 diabetics with cardiovascular disease, with renal problem, and probably added on hepatic is now coming in a big way because of the NASH, being very prevalent in diabetics and obese people. So with that, you see, you will have to revise your targets. And remember that on the other end of the spectrum, when you really attempt 6.5 in a newly discovered type 2 diabetic, and as the disease progresses, probably in the end with complications and all, target of 7.58 or even 8.5 is acceptable. But that is the other end of the spectrum. Most of the time, it should be 7.58, even in most difficult cases. But revise your targets. And of course, you may have to do ambulatory glucose profile in order to minimize hypoglycemia, in order to find out where it is dipping low, how long that low is maintained and sustained, and how bad it is. And then you know how to address the problem by changing diet, exercise, and insulin therapy. Remember, drug interaction is very poorly, taught in our colleges. I must tell you, it's a big blind spot. I don't find graduates talking about drug interactions. You see, and of course, the alcohol, remember, most important, and gastroenteritis in our cases. 2 only I'll emphasize in our country. You see, the gastroenteritis is the commonest cause of hypoglycemia in our country in practice. And you must be extremely careful, instruct your patients on what is called sick day routine and how to change the treatment when they're suffering from gastrointestinal problems. So this is these are some of the methods I told you. You see how you can prevent hypoglycemia, monitor them carefully, do CGMS also, craft your insulin prescription properly, sensitize with anti-hyperglycemic agents and not hypoglycemic agent. You see, maybe use good tools with the good insulins, basal and prandial, you see, and use insulins which do not produce as much variability of response. A few special situations very quickly in 2 minutes. Nocturnal hypoglycemia is particularly bad. When you use insulin dinner, even if I'm using human regular insulin at breakfast and lunch, dinner quite often I use analog. This is one indication, because human regular together with basal given at night can produce very bad hypoglycemia. And nocturnal hypoglycemia is a particularly bad problem because during sleep, our counter-regulatory responses which are initiated when you get hypoglycemia, they are not as active in recumbent position. Catechols are not secreted as fast, or you see the RAS axis also is relatively active in the recumbent position. Therefore, it can be very bad hypoglycemia in sleep. Remember, if you get very variable fasting blood glucose every day, that itself is a clue that there is probably nocturnal hypoglycemia, and you must reduce the dose of your quick-acting insulin at dinner as well as the basal insulin. And very rarely, remember, there is an indication to take the basal insulin to morning time instead of night, when there is a fear of nocturnal hypoglycemia. And remember that in elderly people, you see with age, the gap between the sympathoadrenal discharge, those symptoms, and neuroglycopenia, where patient passes out, is very narrow, so that you don't get much warning, and patient can go very swiftly into bad hypoglycemia. And this is extremely careful in elderly people when you give insulin therapy. I think the impaired awareness of hypoglycemia, another issue which occurs in some patients where there is very good tight control has been done for a while, then there is recurrent hypoglycemia, then they become unaware of hypoglycemia. And in these people, you have to be very careful. You have to really revise your threshold, revise your target of A1C you want to achieve in order to avoid that. And remember, there is a method of relaxing the treatment, let it sugars run a little higher, and then the awareness is restored. But the question is, how long will you continue in the uncontrolled state again? So it is a very difficult situation. You must revise your treatment carefully and revise your targets and play very safe and use the principles that I pointed out. Have to be very, very careful. You see, so I think I'll pass off this rapidly in the interest of time. And I think this occurs quite often in type 1. Alcohol ingestion, you can have unawareness hypoglycemia. Alcohol inebriated state, probably hypoglycemia will not be appreciated. You see, and people with autonomic failure, there will be unawareness. Beta blockers, one always thinks might cause, but really, as in the usual clinical dosage, they are not important in causing hypoglycemia unawareness. You see, so I think the key points are hypoglycemia is frequent with sulfonylurea and you see, and insulin therapy. Okay, and of course it is very risky. I enumerated the important risky situations. So what you should do is improve your insulin plans, stay close to normal physiology, review the insulin injection technique, always use multiple doses. You see, use adequate dose of basal insulin because it causes less hypo. So while using that, the prandial dose comes low. Use good insulin, good quality insulin, which I alluded to, but you will hear a lot of lectures on that on many platforms. You see, sensitize a type 2 patient and set up realistic A1C goal. This way you can give good result to your patient without producing hypoglycemia. Nocturnal hypoglycemia, be very careful. Elderly subject, be very careful. And patients who known to have hypoglycemia unawareness, be extremely careful while you are instituting insulin therapy. Thank you very much for your patient hearing. I'll take a few questions with the permission of Dr. Ashok Kumar Das.
Thank you, sir, for your excellent deliberation. The audience have no questions in the chat box that clearly says that you have made the topic so clear. I request Dr. Ashok Kumar Das to...
Thank you, Sangramji. Thank you very much for giving me this opportunity. Professor Chandelier has given a beautiful, a lucid, and he has made a very difficult thing very simple. And sir, for the making things clear, I will ask you a few questions and also one or two things to Professor Jargar, who is the other panelist today. Now, just wanted to ask you, sir, you said that instead of using insulin, I'm talking about type 2 diabetes, instead of using insulin alone, if you use it as a bits, as a combination therapy, bedtime insulin, daytime sulfonylurea, or any other combination, it is much better. And also with the not hypoglycemic drug, but with the anti-hyperglycemic drug, it is much better. I think your message was loud and clear. I just wanted to know, sir, is there any study which has said that the studies are there which said with the BITS therapy, the hypoglycemia is less because the dose comes down and also oral anti-hyperglycemic agents take over.
Yeah.
What's your personal experience on that, sir? Because out of the patients that we have, all of us have, at least one third or even close to 50% of them are on this combination therapy. A little clarify on that beautiful point you highlighted. Very briefly, sir. Time is less, very briefly.
I think BIT says, you see, you give a basal insulin and you cover the prandial by using good oral agents. Yes. Which oral agents will you use to control prandial very effectively? I would say short-acting metformin, even in the immediate release metformin.
Immediate release. Yeah.
Very small dose of sulfonylureas. Like I use glycoside, and I use something like half tablet of not only 80 but even 40 milligram, half 3 times a day. You get away without much hypoglycemia. And I must tell you that although I have told you not to use sulfonylurea with insulin, but in a difficult patient, this is the best way to sensitize. They are superb sensitizing agents, sulfonylureas. You see,
I think I cannot agree more, sir. The mnemonic said
use that to control prandial insulin, and then you get away with a good basal insulin. You see,
Yes.
I think this can be used after failure of oral agents. This should be the first approach, because
Yes, sir,
acceptability will be very good.
Yes, sir.
But
That is why,
invariably, difficult case, you'll have to keep on adding other prandial insulin, one prandial insulin, then 2, and then 3, and full bowl plan. So I think you can go stepwise. Patients may accept it better. But the patients you and I see have already gone through some of these simple things.
exactly. So they come
So
late.
some of us, we straight offer them. We straight go to the last step, because that is what would really help the patient.
Sir, I think that's why the mnemonic says beats. Bedtime insulin and daytime sulfonylurea. S stands for sulfonylurea. So I think you said very correctly, which is very important. Sir, I just wanted to ask you one question. Have you seen very severe nocturnal hypoglycemia with any particular variety of insulin like NPH or anything, sir? Very severe, below 56, below 50.
I've seen mostly with the older insulins. You see, unfortunately, my journey of using insulin is now 55 years. You know,
Yes, sir.
so insulin, of course, we are celebrating the centenary next year. So so in that I have seen those old ones, NPH and all, and there we have faced bad nocturnal hypoglycemia and human regular insulin. Very bad in type 1 especially is very bad hypoglycemia at night, in spite of making your insulin perfect. Patient is good, patient understand everything.
In fact, sir,
I must say we had bad tools, really bad tools. Even now, I must say that we still need better insulin. Smart insulins, or hard ones, we still need in order to really help our patients.
While we're on these newer advances, may I ask you, sir, can you enumerate? You might not have used it, but from the literature, do you think that the newer insulins that is going to come, like the basal insulin, which has got a higher density of insulin, say like Toujeo, or the insulin which is coming, which is loaded, and also people are talking today of about weekly once insulin, which is on the anvil. You might not have used it. Toujeo you must have used plenty. What do you think about these newer insulins? The smart insulin, by definition, sir, as you rightly said, it is a glucose sensitive insulin therapy. So hypo has to be less. But the other ones, what do you think, sir? Will they stand up to their expectation?
They will definitely. There's be additional tool for us.
Yes, sir.
But how much really come very close to ideal? Ideal is day to day, very predictable response. You see exactly the response the way we want the profile. Whether we'll achieve that, we are getting closer and closer. And of course, the once a week insulin until we use, I would not be able to comment
sir,
on that.
final two questions because time is less. Sir, the Murug, I call him Murug. Murug spoke about the EKG in hypoglycemia.
Yeah.
There is lot of fear and concern. Sir, we have also encountered the other cardiovascular disease effects with hypoglycemia. What have you encountered in your long years of practice? CV defects with hypoglycemia.
Yeah, I think with recurrent hypo, which sometimes I've seen in type 1 years ago, nowadays we don't, because all the difficult ones, if they can afford, we put them on pumps. I got good number on pumps for now 30 years my patients have been on pump. See, I got a type 1 who is now 70-year-old and using pump for last 40 years. See, so
with pump and
totally free. But otherwise, frankly, it is a serious problem. It is a serious problem.
Sir, I just asked you last two questions. Sir, you said about the glucose glycemic variability as one of the forerunner for the insulin-induced hypoglycemia.
Yeah.
So, do you have any particular? You said about the basal, that is absolutely correct. I have to agree with you. Do you have anything else, any other insulin which has lesser glycemic variability from the experience, not from what they claim? Any other insulin just lesser?
I think it's very interesting. Human regular and short actings have less variability.
Exactly.
all basals have more. NPH has tremendous variability, 30,
Yes,
40% variability.
Yes,
Glargine about 30.
okay.
The newer basal, the Glargine 300 is getting better.
Getting better. That's why
The
I asked.
variability. There is probably 20, but I must tell you something very interesting. None of the papers where they compare one even against the other head on even, they give the absolute figure of variability they are not given. Maybe if we
Exactly.
see raw data, they are not given. You see,
Yes, sir.
they say we are better, one is better than the other, one during the adjustment phase, during, and other one is better in nocturnal, and other is better, so that sort of comparison figure is there. But absolute figure of variability, you see, I feel that it is still 15 to 20%.
Sir, thank you very much. Sir.
That is
Thank you
never
very
brought
much.
out in any of the papers. You see those papers carefully, you won't get the figure. You won't get the figure. They'll give the comparison and percent. The rest you have to guess.
Yes,
Just have to guess.
Sir, I think, sir, wonderful. The questions are plenty, but the time is short because we have to listen to others. We started a little late also, sir. So I will just ask one last question to our panelist, Dr. Jargar. Sir, Professor Jargar, I want to ask you that a very, very important practical topic, that how often you have found patients taking insulin and alcohol and landing what Professor Chandela described, that hypoglycemia because of alcohol and on and above that insulin.
I must tell you, firstly, Professor Das, listening to Chandalia Saab almost is
Wonderful.
like...
It was mesmerizing. I give a big hands for him.
It's like having seen what one has seen in life in totality.
Yes, exactly.
Thank you.
You know, when we started endocrine practice, imagine the whole art of diabetes ultimately came down to managing hypoglycemia.
Exactly.
Right from chloropropamide days, sir, I'm sure only Chandalia Saab would be, and Sashya Saab must have used tons of it, and then Manjal Saab, rest of people lesser.
Yes. And
And
the
they are
preparation
going
called...
to glycoside, otherwise, the best hypoglycemic chloropropamide and glibenclamide.
Yes.
If you go to the potency of it as a hypoglycemic agent, the whole gamut was reducing hypoglycemia.
That is why
Then
Dr. Jargar introduced chlorpropamide with metformin. That
the
was
whole gamut of improvising insulin is from NPH to Glargine to Diglodac or weekly. Just the phenomenon of reducing hypoglycemias.
Absolutely.
And of all popularity of GLP-1 receptor agonists and potential weekly insulins, the only ultimate advantage would be hypoglycemia. We know that nocturnal sudden death is twice common in diabetics than in non-diabetics.
Absolutely.
And many of us think it is because of the arrhythmias, and most probably related to those nocturnal hypoglycemias.
Exactly.
Alcohol and insulin causing hypoglycemia is quite a bit seen, but because alcohol consumption is relatively minimal in Kashmir.
Yes.
So this is something that we are not seeing much here.
Thank you, Dr. Jargar. Thank you very much. And that we'll again come back for the next topic to you. I thank Professor Sangram Biradar for having given the opportunity. Over to you, sir, to invite the next speaker. If I took longer time, please excuse me, sir. It's a very interesting topic. So, and sir, the time is ours. If it is 8 or 8:30, doesn't matter. I mean, it matters, but sir, we have to have a good discussion. Having called all of us here, we'll give something to the audience which they will preserve. Thank you, sir. Over to Professor Sangram.
Thank you.
Thank you, Dr. Chandalia, sir, for your excellent deliberation.
Thank you.
And for sparing your valuable time of 1 hour, which enlightened all our audience. There is no thought about insulin means Dr. Chandalia. That is the thought, take home message from you. I thank once again for joining virtually, sir.
Thank you.
Now I request our next speaker, Dr. V. Sheshaya, to deliver his talk on a step towards strategy for prevention of diabetes. Over to Dr. Sheshaya, sir.
Respected Dr. Sangram, thanks for inviting me on this webinar program, and I must appreciate my chairpersons will be there, Dr. Das and Dr. Jargar. The both of them are been working in the field of pregnancy and diabetes for long years. So I'm very happy they have been to moderator for my talk now. Now I want to speak on a step towards strategy for prevention of diabetes. So now we all know in the world now the people living with diabetes 463 million, and in about 2045 it is going to be 700 million, and a 51% increase. That is going to be very, very problematic. Now, what we can do for this problem? Move to focus for the prevention. Where to find the answer? That is my topic now. So we all know the epidemic of diabetes is like that. The increased prevalence of diabetes is usually attributed to the aging population, urbanization, obesity epidemic, and physical inactivity. These very commonly known factors. But what is more is, well, all these factors contribute to the epidemic of diabetes. Intrauterine programming or exposure or gestational programming or emerging as a potential risk factors, but I don't think much attention has been given for these factors. So all the four that discuss more, but they miss this particular topic, and I'm very happy that Sangram invited me to talk this topic. Now, and we must remember this man, I think we must celebrate his birthday. I don't know what his birthday, Dale Barker hypothesis. This is one hypothesis I always quote because, but for him, we wouldn't have known what was happening. He said, first, the hypothesis that very important statement he made. The body's susceptibility to lifestyle diseases were programmed intrauterine. He is the first person to say everything starts from the uterus. So that may be true. Now I will discuss how it is going to be true. Now intrauterine programming, what happens here, intrauterine or gestational programming is a process. There will be stimuli, there could be hyperglycemia or stresses that occur at critical or sensitive periods of fetal development. But the problem is permanently changes, that's all. Once it occurs, it becomes change. Structure, physiology, and metabolism is predisposed individual to disease in adult life. That is the reason why I quote this man all the time when I speak here on this fetal origin order diseases. So it is now we are almost coming to the answer. Prevention where to start? Fetal. Now having known that, what is the definition of that? Hyperglycemic pregnancy, GDM or gestational diabetes is defined as any degree of glucose tolerance with onset or first recognition during pregnancy. And the concern about this problem is, as I told you, GDM represents detection of chronic beta cell cycle. That means already she is declaring I am going to be diabetes. In future, that is type 2 diabetes. And again, GDM is a stage in the evolution of type 2 diabetes. That is the biggest problem of hyperglycemic pregnancy. She is going to be diabetic in the future. Not only that, now the another problem will be here, hyperglycemia pregnancy may play a crucial role in increasing prevalence of diabetes and as well as obesity. Not only that, it can also lead on to origin of non-communicable disease. Now you can easily follow up the fetal origin is going to give us such an amount of problem in adulthood. Now next point I'm going to discuss here will be here, prevalence of hyperglycemia pregnancy. What is prevalence here? The IDF data shows in 2019, the global prevalence of hyperglycemia pregnancy, the age group of 20 to 49 years was estimated to be 20.4 million or 51.8% of live births. That's a huge problem of this problem. Now, if you look at the world itself as it is, you will see, unfortunately, Southeast Asian region, the highest prevalence of diabetes, India comes to that, 26.6%. And it is also known that 1 in 6 live births occur to women with some form of hyperglycemia, 84% of which are due to GDM. Now, what is the implication of this problem? Now, women with GDM are at increased risk of future diabetes, as I told you earlier. Predominant type diabetes, as are the children. She is carrying a child, but the child is at the risk of developing diabetes. That is what we call transgeneration transmission occurs. One generation to another generation. Now, the beautiful explanation given by modified Frenkel hypothesis or Frenkel-Pedersen hypothesis, formerly it was thinking only glucose was the cause. Now, after Frenkel joined with Pedersen, they come with different concept now that is called mixed nutrients. Pre-diabetes, GDM, insulin level is low. So what could happen in the nutrients, glucose, amino acid, lipids, all these mixed nutrients cross the placenta and goes to the fetal compartment. In the fetal compartment, the mixed nutrients stimulate the beta cell of the fetus, insulin secretion goes up. So insulin is available, nutrients available, the child becomes fat, macroscopic fat, fetus. When this child is born, immediately after the child birth, the fetus, newborn can go to hyperglycemia because there are no more glucose available, so they go to hyperglycemia. That is one important point. But the most important point for my talk here will be here, when they become adult, this is the biggest problem here. If you go to male child, the child may become obese or they may develop IGT, impaired glucose tolerance, ultimately adulthood diabetes. Suppose that child happens to a female child, again the obesity, but instead of IGT, this is called GDM here. This GDM woman will become diabetic. The problem here is it starts here. Mother, parent diabetes, now child born is going to be diabetes, and this is called vicious cycle here. This will become, this child again grows up, or female child grows up, she will become diabetic and goes on like that. And that's called, and again the child comes back here, vicious cycle of diabetes begetting diabetes. That is very important point we have to keep in our mind. One child becomes diabetic, it goes on become diabetic. And for this, what we can do, now maternal glycemia and child glucose metabolism, across the maternal glucose spectrum, export to higher levels in utero significantly associated with childhood glucose and insulin resistance, independent of maternal and childhood BMI and family history of diabetes. That shows again here hyperglycemia is very important, not only in children, but when it's adolescent period also, that can give a problem here. Adolescent offspring of women with GDM show increased adiposity and adverse cardiometabolic profile and earlier puberty among girls. And then increased fasting glucose, normal higher levels among the offspring of mothers with GDM may be explained by the programming effects of the hyperglycemia and pregnancy. You will see from childhood, in adolescent, the whole problem is again from hyperglycemia in the mother. Now, when GDM is constant with adult offspring, when they become old, because of their mother had a pre-GDM, chronic resistance, beta cell failure, dyslipidemia, inflammation, endothelial dysfunction, all these things would result in the adulthood. Here will be type 2 diabetes, or they may develop cardiovascular disease or metabolic syndrome. So, from hyperglycemia in the uterus, lead on so much of problem in childhood, adolescent, and also adults. Now, having known this, what should you do? You need universal testing. This is defined by all women. You should be screened for gestational diabetes mellitus even if there are no symptoms. Actually, government of Tamil Nadu has given the order mandatory screening for GDM is mandatory in all our in the state. So let us see what we can do. Now, here screening for gestational diabetes mellitus, what are determinants here? If we going to be any problem in the early weeks of pregnancy, that is first trimester, organ development will get involved. And then the second trimester, the child, if mother had hyperglycemia, the child will have behavior abnormality. And then in the third trimester, is hyperglycemia occurs, anthropometric and metabolic change will occur. So any time of the pregnancy, all this can occur. The most important, as I told you, in the first trimester, on the early weeks of pregnancy, central nervous system most sensitive. Occurs within 9th week, and heart again within 6th week or 7th week. So you will see by this diagram, by 9th week, almost all the organs are developed. So the aim, by point I want to make here is, do not wait for 3rd, 24th week. Even early week itself must screen, because otherwise the child may be born with congenital malformation. So before 9th week is very, very important. But anyway, let us see what happens next slide. Important the first trimester. What is important here will be, the first trimester begins on the first day of the last period, lasts until the end of the week 12. This means that by the time one knows for sure of a pregnancy, she might already be 5 or 6 weeks pregnancy. A lot happens during this period. So one has to be very, very careful. The moment the woman thinks that she has missed her period, she must go to our obstetrician and check whether she has got any abnormality, any abnormal blood sugar she has got. So here, why this part I am making here will be, if we take the islet cells in the fetal pancreas, the islet cells function as an endocrine organ. Appears the 11th week of gestation, recognizes and responds to maternal glycemia at 15th to 16th week of gestation. So 10th week is very important organ development. Again, till about 15th to 16th also you will have problem. So early maternal metabolic imprinting may affect the fetal growth. That is the reason why including maternal hyperglycemia and fetal growth here, this is beautifully defined here. The priming of the beta cell mass in early gestation may account for the persistence of fetal hyperinsulinemia throughout pregnancy, the risk of accelerated fetal growth even when the mother enjoys a good metabolic control in later pregnancy. That is very important statement made by this workers, Carpenter. That means what he says is they must screen pregnancy in the hyperglycemia in the early weeks of pregnancy itself. You will see in this slide now, we have done the study here. If 207 pregnant women, irrespective of trimester screen with 70 kg of OJT, among them we found about 87 had GDM, that is 42.303%. In then group 1, screen less than 23rd week, 24th week. So group 2, between 24 after 24th week. There are two groups. When followed up with them, what has happened was, in the first group who were less than 23 weeks screening and taken care, the outcome was birth weight of unit was only 3.13, that is normal weight. Whereas in these people detected beyond 24th week, not earlier week, and then in spite of treatment, they had 3.4 to plus or minus 5.8. That means Indian newborn babies, birth weight is 2.5, 3.5. So all these people, in spite of treatment, we are not able to avoid macrosomia. So manifested GDM in the early weeks of gestation is common. That is, this is we found here about screening about 11,785 pregnant women with the trimesters. It is very high first time itself. It just are not known. Very people have always think 24th, 28th week, but you will see in this study, in this 31.5% were diagnosed of GDM the first trimester, 42.2% second trimester, and the third trimester 20.3%. That means almost 70% of the people were diagnosed less than 24th, 28th week. So that is the moral of the story is that necessitating early weeks of screening, and then need for testing in the glucose tolerance in the early weeks of pregnancy. That is what we recommend. And then now we come into the having understood when to screen. Now how to screen them? Now you know this slide is very, very informative. OB/GYN clinic, there is a private clinic in a 5-star hospital, 5-star centers, endocrine clinic, diabetes center. Any test possible because they are affordable. Anything you do, they will do it 4 times, 3 times, 8 times they will do. But what I am concerned as a clinician here, where we do see this people needs is simple, economical, because most 70% of our population live in less societies than the community health center. Here you will see people here, this is a group. These groups they can't afford any of the tests which you want to recommend for a clinic. So this is a community problem. So here what we need is the guideline, diagnostic criteria which are simple and feasible, and the ground is important. So this is the message. Then what we should do, what is happening in the world, what is happening in India. You are surprised to know this is what happened. International Association of Diabetes Pregnancy Study Group. Many clinicians still follow. I don't know why they want to follow, but you will see here, these guidelines are based on the hyperglycemia and pregnancy outcome study group, which include only the Caucasian population. They never did the study here. It was not only in the Caucasian population, except 2 cities, Bangkok and Hong Kong. But they are pressurizing everybody in the world to do this guidelines. But unfortunately, this is what happened. And this is definition of World Health Organization, in Newcomb endorsed it because there's no other way. Because it has come from American study, IADPG. It described the quality of evidence for its recommendation as very low and the strength of its recommendation as a weak. In spite of that, they recommended. Then let's see what happened. And finally, this is a nail. IADPG guidelines have become obsolete. This is published by Dr. Benson itself in about 2018. Even at centers that accepted IADPG recommendation, the approach varies and needs revision for standardization of the strategy for diagnosing GDM. So I want to say that the IADPG guidelines is okay for them, but not for us. So another thing comes happening here. Most of the people say you do fasting, without knowing our South Asians metabolism is different. In the case of fasting blood to diagnose GDM, in relation to fasting blood glucose, there is a considerable variability between countries noted in the APO study. The Caucasians with the FBG diagnosis only 22% GDM in women in Bangkok, 26% in Hong Kong, compared to 71% in some US centers. So United States, European countries, they can do fasting. But South Asian countries, when they cannot, by fasting, you are going to miss many of the people, the GDM people. So it is not recommended. We don't recommend fasting blood sugar here. Again, we have done this work in our country, in our state. A low diagnostic rate of FPG has also been reported in Asian Indians with a fasting plasma glucose of 92 milligrams, diagnosed only 24% of GDM. This has been published in Strategy for Implementing WHO criteria. So, nutshell is fasting plasma glucose is not ideal for our population. Then we did a long time study, almost like IADPG. A prospective study was undertaken to elucidate a test procedure. The rest was last minute because the simpler test. You don't expect the people to come with fasting. A 2-hour PG more than 140 milligram, 70 gram oral glucose, administered in a pregnant woman in the fasting or non-fasting state, without regard to the time of the last meal, able to identify a woman with GDM. And this was published in the Acta Diabetology a long time ago, a single test procedure to diagnose just GDM. Now this test procedure has been accepted by Diabetic Study Group India, single test procedure to diagnose GDM. So we will now see what could happen. There's some discussion will go on. There may be approved, there may disapprove, there may be argument. You will see here. Now, what is the value? Why you are telling 140? If we take this insulin level, normal glucose tolerance, IGT, type diabetes. When anybody becomes impaired glucose tolerance, then almost when blood sugar crosses 140 milligrams, you will see 50% of beta cell lost, not dead, function is lost. So that means 140 is a critical level after which 50% of beta cell function is lost. So FIGO says, it's a readable statement, if in the non-pregnant state, 2-hour PG more than 140 milligrams is considered abnormal, that is IGT, then why can't it be considered abnormal during pregnancy? Because I recently, about 1 week ago, I saw a paper, they keep 200 milligrams as diagnostic criteria. I don't know where they got it. I have not seen anywhere 200 milligrams, but it has been published also in JAMA. So this is 140 is a value which you can remember. This is the again evidence is that IGT 140, then why can't it be one beta cell function is lost, and then it is IGT value, and lastly, still you have got doubt, the prevalence of GDM corresponds to the prevalence of IGT within a given population. So IGT is 12% in the area. I'm sure GDM also will be 12%. So I have dealt with that, GDM diagnosis and management. Here I am trying to explain to you how the 140 milligrams is a very important number of points are shown. Now final nailing you will be here will be the RCT, random control trial. This trial cannot be repeated. That's all. It is first because no woman will, cannot, you have to treat every woman. You can't say no, I want to go and see what happens to you. So this study was done in Jammu. Jargon must knowing about this place, Jammu is there. What happened here? The normal control 140 is a very interesting. GDM with treatment 70, without treatment 62. Stillbirth in them was in the GDM not accepted. Very rare. Somehow I don't know why the people didn't accept treatment. And then on follow-up they found about 3 people had a stillbirth. And preterm delivery to 2.8% control group was almost double GDM with the treatment, almost 4 times in people without treatment. And then respiratory syndrome most common seen only in the people who are not treated, and macrosomia 1.4, 2.8, 9.6. You will see here, GDM women diagnosed but not accept any treatment had this problem. So this study was published in JAPI. This study proves advantage of adhering to DIPSI guidelines, diagnosis of 2 PG more than 140 milligrams, and management of GDM for a significantly positive effect on pregnancy outcome. So this is first and last study. Nobody can do that. So we can conclude now. Diagnosis of GDM 2 PG more than 140 milligrams, and treatment is worthwhile. The decreased macrosomia rate, fewer emergency sections, serious parental mortality and morbidity, and may also improve the women's health regard corridor. Number of studies have shown this 140 value. Now, fortunately, our government, Ministry of Health and Government of India, as 2014 they first released, then again 2018. Not only now Government of India has approved this criteria, approved WHO, FIGO, the IDF here will see single step procedure, diagnosed GDM and recommended by WHO, and then FIGO, and again also in IDF. So now the matter is almost closed. That is, you have to follow only Government of India. One more very happy to share with you, see the DIPSI guidelines, 2014, what they took in IDF, 7.8 millimole per liter, is 140 milligram diagnosed. That is included one of the guidelines for diagnosed GDM. It is a very heartening to see nice guidelines. Nice OM is selling good here about 2015 against 7.8 millimole. Nice is like India. The number of population are there, ethnic population, Indians, Pakistanis, everybody is there. So nice guideline is a good guidelines compared to other, because there are mostly Caucasians. So heart of the matter, my final talk will be here. GDM is an important problem at all levels of economic development, but immediate and pragmatic considerations may limit the resources devoted to this issue in developing countries. So here you will see here, pregnant women in low and middle income countries are not consistently screened for GDM, because how can they do 3 blood tests? Even though those regions account for 80% of global deliveries, 88% of GDM cases. This is all because of the unnecessarily we are stressing the people to undergo this huge test. So a simpler solution, and you must very happy to know the single test procedure, the single glucose value is a walk-in test to diagnose abnormal glucose tolerance in the pregnancy. The rational, cost-effective, and cause negligible inconvenience to the expected mother. So this is a make indicators. I think this only guidelines Minister of Health government have approved. No other guidelines for early diseases. Minister of Health, I don't think has given the guidelines. Association has given guidelines, but Ministry has given guidelines only for the pregnancy. The conclusion will be here. Prevention of diabetes and obesity, epidemiological evidence will be here. Care during the preconception period, very important. Pregnancy and postpartum are desperately needed. This latest publication, 2020. And then St. Vincent Declaration states that achieve pregnancy outcome in women with diabetes, the approximate that of women without diabetes. So that health for all. Then what could happen here? This is very important slide for all of us. You see here I put red mark. ADA says 95, whereas American College of Obstetrics says 90, just like DIPSI 90 only controlled glycemic targets. I don't know why 95. It's a simple question. When you diagnose GDM with 92 milligrams, how can you keep 95 as a cutoff value for treatment? It's a simple question. I don't know who would answer that question. The goal is to obtain newborn baby's birth weight appropriate for gestation age, a step to prevent offspring development GDM, because if you achieve this weight 2.5 to 3.5, probably the child will not become diabetes. So if this is what we have done. Also, it is not theoretical. We have seen that in our own studies, National Family Health Survey, SGA 17%, LGA was 90%. Small for this, right? 17%, large for this was 90%. Because our intervention here, we are able to bring it down to 41.2% small for gestation age infants, large for gestation age infants. Here it will be again 63.1%. Though it is possible we can do that. The single initiative of achieving birth weight of infants appropriate for gestation age would have significant positive effect on the overall health of the family and the community. So finally, female gender, the key to non-communicable dispersion, how it starts with the healthy pregnancy. If low birth weight baby, large gestational birth weight, in adult life, they develop elevated risk for the obesity, diabetes, hypertension, and cardiovascular diseases. Intergenerational transfer occurs. So maternal health is linked to the NCD epidemic. So what we need is, ladies and gentlemen, optimistic outlook. Here, it is necessary to optimize metabolic control early in pregnancy. This will necessitate pre-pregnancy planning. That is very important. Pre-pregnancy planning for women with pre-existing diabetes, as well as for those at decreased risk of GDM. Better means to safely normal glycemia. So my final message will be here. My topic was a step towards strategy for prevention of diabetes. It is possible because GDM offers an important opportunity for development, testing, and implementation of clinical strategies for diabetes and cardiovascular disease and prevention. So, friends, ladies and gentlemen, I make it very simple now. Most complicated problem in this universe has a simple solution. Albert Einstein. I am also giving simple solution here. One test, 70 gram oral glucose, irrespective of the last minute timing. That's one test. And then one value to diagnose GDM, 2 rpg more 140 milligrams, and one target 2 rpg more or close to 120 milligrams. So this is way you can probably prevent diabetes in the world. I hope this is my concept. Let us see what our chairperson say, moderators say, and our audience is going to respond to this talk. Thank you very much.
Sir,
Thank you, sir, for your excellent deliberation. Made the topic so clear. Our colleagues of gynecology will be having so many questions. We will take the questions later on. Now I request Dr. Professor Anil Bansali, sir, to deliver his talk on paradoxes in diabetes mellitus. Yes, sir.
Hi, Anil. Good evening.
Good evening, sir.
Anil, long time no see. Thank you very much for joining.
Hope everything is fine, yaar. आज बहुत दिनों के बाद देखा.
Post COVID.
But that is a passing event. Anil, forget about it.
आज आपकी बड़ी याद आई थी. Honestly, आज आपको मुझे लगता है साथ बहुत मुद्दत के बाद सुना तो दिल्ली में वाले प्रोग्राम में दिखे नहीं थे.
I'm just opening the slides, sir.
Yeah.
Share कैसे करना है इसको? अभी पता है.
Alternate date पे थोड़ा down करो, so that we can help you. I'm also on the screen. I don't want to come. Where is all this?
Slide is this.
The slide. Where is the screen of this?
Screen कहाँ से?
You are using the screen.
Yes. Share.
Yeah. Drag your slide.
कहना आवाज ले ले रहा मुश्किल से.
बस मैं डिपेंड वन.
जैसी जगह बस.
दरवाजा बंद.
की लिखा था इधर.
जगह लेके.
मैं कुछ को
रुको ना ले आवाज. ये म्यूट पर कर ले चाहिए.
You cannot किस कॉल का मुँह कॉल दे लियो किस को you cannot.
वो कितनी बार सिखाया है? Why do you forget it? हैं? There is a share screen.
Yes.
வாயில இருந்து என்ன வருதுன்னு சொல்லிட்டு பாக்குறாங்க.
Dropbox में.
एक मिनट ना यार, ये आ गया. This. But this is your desktop.
It was there. That paradoxes in type 2. I saw that slides.
Yeah, yeah.
Just open it and put
We should put a share.
green
Is it,
share screen.
just
Just open that file and say.
I'm doing that. And just wait. Can't you wait?
Okay, sir.
Yeah, yeah.
Got it.
Clearly visible. Clearly visible.
Okay, sir.
I think it's
You can make it full screen if you want.
Thank you. I'm sorry for the delay. The delay was because of the technical reasons. So thank you, Professor Sangram, for inviting me. And nice to see Professor Das, Professor Jargar, and so many elegant and distinguished colleagues. So I will be happy to deliver a talk on paradoxes in diabetes mellitus. The talk is slightly unconventional because this is just a thought process, what we see or regularly see in our clinical practice.
Wonderful. Jen.
So quantitative founder includes diagnosis, clinical examination, something paradoxes we observe in management, which includes both for lifestyle modification and anti-diabetic medications and complications. For a diagnosis of diabetes, I think we are all aware of these 4 points, which we usually take into clinical practice. Either the random plasma glucose, but with symptoms more than 200, fasting is more than 126, 2-hour PPG after 75 gram glucose load is more than 200, or hemoglobin A1C is 6.5%. The GTT, or a random plasma glucose with symptoms, is still considered as a gold standard. And I think the best gold standard is considered as a GTT only. But hemoglobin A1C have also been mentioned in the literature, and we were also part of the contributor to that hemoglobin A1C can also be utilized for making a diagnosis of diabetes. However, there are dichotomies and there are discordances in many of the scenarios. Let us see that how much the fasting plasma glucose and hemoglobin A1C correlates. So it only correlates in half of the individuals, while in rest of the half, either the fasting is more and hemoglobin A1C is less, or fasting is less and hemoglobin A1C is more than 6.5. If we take a correlation with a 2-hour PPG and hemoglobin A1C, it becomes further worse, and it is only a 1/3, which is in concordance with the hemoglobin A1C of more than 6.5 and PPG of more than 200. So meaning by that, the concordance with fasting is almost in 50% of patients, while the concordance with PPG or with the 2-hour PPG is only in 1/3 of patients. So you have got a large number of the people. If you are using a hemoglobin A1C as a diagnostic tool, then the large number of the patients either can be missed or can be overdiagnosed. So if you see further, data from the China only, and that shows that the concordance in both fasting and plasma glucose is around 53%, while if there's a concurrent iron deficiency anemia, as the erythrocyte turnover is very fast, you can have around 75% of the patients will have a concordance. Similarly, if you talk about that, data from the Caucasian population, which shows that the A1C fasting and this, so almost 1/3 again here, with a 2-hour PPG, while with the fasting plasma glucose, it is almost around 40% with that, and the rest 60% do not in concordance with your hemoglobin A1C. If you go further, this is data from our center, which we published in 2009, and what we showed that at hemoglobin A1C of 6.5%, which was compared with the GTT or a fasting plasma glucose of 126, and showed a sensitivity of 65%, while it was a specificity of 88%. Meaning by that, 35% of the people will have a discordance with that. If you go further, so why the possible reasons for why you are having a discordance with the hemoglobin A1C and glucose values? That is because the hemoglobin A1C is a measure of cumulative glycemic burden. So it represents only a recent explosive onset of diabetes may not be correlate with that. Coexisting anemias can also have a problem with that. As I mentioned, if someone has got an iron deficiency anemia, then high erythrocyte turnover can lead to higher hemoglobin A1C, hemoglobinopathies, and another entity which is called as a slow versus fast glycators. Like Asian ethnics, they are fast glycators. So even at a higher blood glucose, they usually glycate faster. So even at a hemoglobin A1C 6.5% is considered as a diagnostic for the type 2 diabetes or diagnostic for the diabetes. So even at a 6.3, it may have a better concordance with a fasting plasma glucose of 126 over a 2-hour period. And aging is another, because as age, the deglycation of the hemoglobin A1C is also slowed down. That's why with the aging, you can have a higher glucose values. And this is our data, which we showed, is that as the age advances, your hemoglobin A1C, despite they are having a normal GTT, from the age onwards of 60 years plus, the people had a hemoglobin A1C of 5.7, which comes in a pre-diabetic range. So meaning by that, so what we should do in this scenario, we should try to take out this scenario that the concurrent iron deficiency anemia or concurrent hemoglobinopathies should be excluded, or should be taken into consideration if you use hemoglobin A1C as a diagnostic criteria. If baseline hemoglobin A1C is abnormal, even the GTT may not be in a diabetic range, then you repeat one more hemoglobin A1C. If it is higher than 6.5, then because it has got a specificity around 88%, so your diagnosis of diabetes is confirmed. So that's why we should be cautious when you are using hemoglobin A1C in establishing a diagnosis of diabetes. The next is the paradox in clinical examination. You can see these are the two phases of insulin resistance. One is manifested as a grade 4 acanthosis nigricans, while the another is manifested as a lipodystrophy. So in a lipodystrophy, you have got an abnormal insulin receptor, and you have got a severe insulin resistance, and insulin levels may be in thousands, and you have got two phases of the insulin resistance, which you see in clinical practice. Similarly, like a Dupuytren contracture you see, which may not only be present in diabetes, but most commonly present in chronic liver disease. The other paradox which we see in a clinical scenario, The other paradox which we see in a clinical scenario is the absence of pulses and presence of foot ulcer. So if you have an absence of pulses and presence of foot ulcer is there, it is likely to be ischemic. If the pulse is bounding and patient is still having a DFU, then it may be Charcot's or a neuropathic ulcer, or maybe a small vessel disease. And if the pulse is absent and DFU is also absent, then you have got a coexisting collaterals or a normal aberration in 10% of patients. So these are the slight paradoxes which we see, or these are the paradoxes which you see in clinical practice. Many times when you examine the foot, no foot ulcer and pulses are also absent. Now we talk about the therapeutic aspects and paradoxes. So there is a weight regain despite continued LSM is a observation made by the most of the physicians in clinical practice. That the patient always says that I am exercising or I am adapting to the lifestyle modification in a similar way of what we are, but initially I lost weight and now there is no more loss of weight. This can be explained by the adaptive changes in adipocytes following weight loss, and the phenomena is called as adipocyte starvation. Whenever there is a loss of fat from these adipocytes, they become stressed. And the stressed adipocytes has got a decreased lipolysis, decreased free fatty acids in the plasma, so it increases energy intake and decreases energy expenditure. In addition, the decreased lipolysis is associated with the more expression of the blood and the fatty transporter acid binding proteins. So you have got a more uptake like this. In addition, the stressed adipocytes, they also produces a more retinol binding protein 4, which also stimulates appetites. So meaning by that, your adipocytes which have been starved, after some time, they do the homeostatic mechanisms are in operation to regain the weight, and what we call as a yo-yo phenomenon. So this is usually seen in clinical practice that despite continuing with the same quantum of the lifestyle modification, the patient is no more losing weight. The next paradox is, we always talk about the weight loss is ideal for type 2 diabetes, and even to remain healthy, you should have a weight loss. But in a what scenario, weight gain in type 2 diabetes is healthy? Let us see that. The fat topography in patients with type 2 diabetes, the fat everywhere is increased. There is increase in subacute, intra-abdominal, hepatic, arterial, muscle, and pancreatic fat. And let us see that. And this the term was coined when the SGLT2 inhibitors and GLP-1 analogs were introduced, the KG-A1C paradox. Whenever you try to attempt to reduce the hemoglobin A1C, the weight gain is imminent. However, these two class of drugs, or even DPP-4, which are weight neutral, can help by even decreasing, even with a decrease in hemoglobin A1C, you may not gain weight. If you go further, the weight most of the anti-diabetic medications is like this. So with the insulin, with the DPP-4, weight neutral, and remember the metformin is also weight neutral. Let us see that. And the weight gain, every 1 kg weight gain due to type 2 diabetes leads to around 7% increase in the risk. So weight gain is never good. If you see another data from the Swedish National Diabetes Registry, the total mortality, CVD, stroke, and CSD, they are increased with increasing BMI. So there's nothing ambiguous about that. The weight gain is associated with usually high morbidity and mortality. But in a proactive trial, the only one factor which predicted that participants would not die, what is that factor? And I think you will be surprised that was a weight gain. So what happens with the weight gain in a proactive trial with the pioglitazone therapy? The weight gain with type 2 diabetes is healthy, and you can see that with the use of pioglitazone, there was a decrease in fat everywhere. The subacute fat definitely increased, but the visceral fat remarkably reduced. Hepatic fat also reduced. The TG-FFA also reduced. Intramuscular fat. So you see the fat everywhere reduced, except the subacute fat which increased. So there is a more redistribution of the fat, but the dangerous or detrimental fat, that is a visceral fat, everywhere it was reduced, and even the pancreatic fat, which was also reduced. So if you go further, yes. So this is another study from our department which we published, the effect of pioglitazone and metformin on adipocytokines. And what we showed that there was an increase in adiponectin with pioglitazone, while with the metformin there was no increase in adiponectin. Leptin was significantly reduced by metformin, but not by the pioglitazone. If you go further, another paradox which we see in clinical practice is use of insulin in insulin-resistant states. We all know that the type 2 diabetes is insulin-resistant state. They are partly insulin deficient. They do have a beta cell dysfunction. So we initially use OHS and later on insulin. But it is not surprising. Why do we use insulin even in an insulin-resistant state? The explanation is this. So if you see this dose response curve, normally only 10% of the insulin receptors are functional. The rest of the 90% of insulin receptors are basically spare. So they are not in use. You can overcome, so you see in patients with type 2 diabetes at any given point of time, the total glucose uptake is lower as compared to controls. And even with the increasing insulin, at any insulin concentration, you can see that the glucose, tissue glucose uptake is lower as compared to controls. You can overcome this, or you can attain the same response by increasing the doses of insulin. So this is a shift of the dose response curve to the right by increasing the doses. So you can overcome the insulin resistance by increasing the doses of insulin. That's why we are using insulin even in patients with type 2 diabetes to overcome the insulin resistance when we really fail with oral hypoglycemic agents. The next question which we see in paradox, and because you have a lot of plethora of drugs now available. So our vasculoprotective anti-diabetic drugs are always cardioprotective. I think the answer we have to dissect it is that all vasculoprotective drugs are not cardioprotective and vice versa. Let us see some data on this. First is the SGLT2 inhibitors and cardiovascular outcome. And if you see that the risk reduction for a heart failure, irrespective of any SGLT2 inhibitor used, there was a 33% risk reduction, and it was more attributed to change in myocardial metabolism as well as the hemodynamic effects. If we talk about the GLP-1 receptor and cardiovascular outcome, then you find there was a 13% reduction in this, and which was statistically not significant. If we talk about the heart failure, it was not significant, but if we talk about the 3-point MACE, there was a significant 13% risk reduction, which was statistically significant. If we talk about the pioglitazone reduces cardiovascular events, yes, it does. There was a 16% risk reduction in a proactive trial, and there was a 25% risk reduction in another trial in a meta-analysis. So there was a risk reduction for a cardiovascular event, which was significant with pioglitazone. However, if you look for in a proactive trial, there was a 47% risk reduction in stroke. If you go further, and this was attributed to the change in atheroma volume, which you have with pioglitazone. But if you look for heart failure, then the things are bad. The pioglitazone has got in fact, there was a 41% increases for heart failure. So meaning by that, a drug which may be a vasculoprotective may not always be cardioprotective. Like SGLT2 inhibitors, they are both cardio and vasculoprotective. GLP-1 analogs, they are more cardioprotective than, they are more vasculoprotective than cardioprotective, because on a heart failure, there was no significant benefit with the liraglutide. Similarly, for a pioglitazone, it is vasculoprotective, but not the cardioprotective. So this is the summary of all these drugs, which you can see that. So how these drugs have got a different effects on different outcome, cardiovascular outcome. The another paradox which we see in clinical practice is the decline in EGFR, yet there is a renal protection. This we see usually with ACE inhibitors and ARBs, but we also see with the anti-diabetic medications, and you can see that there is an initial decline in EGFR, and later on again it reaches a plateau, and it is maintained for at least 6 years in there. While in a placebo group, you have a continuous and consistent decline in EGFR. And you also see there is a regression of albuminuria, and the progression of albuminuria is prevented. The mechanism which is attributed is the restoration of the tubuloglomerular feedback. The restoration is tubuloglomerular feedback, and what it shows that with an SGLT2 inhibition, there is a constriction of the afferent arteriole, and this leads to, because which is mediated by adenosine, and this leads to reduction in intraglomerular hypertension, and eventually leads to improvement in renal outcome. Next is the worsening of complications with intensive treatment. This is another paradox which we see in clinical practice. We always say go for intensive treatment or individualize the treatment, particularly those who require intensive. And let us see that the diabetic retinopathy worsens, and there was a 13% of participants had a early worsening of retinopathy in the intensive arm. The other complications which worsens with diabetes intensive treatment includes macular edema, worsening of retinopathy with liraglutide, and worsening of neuropathy with intensive insulin therapy. Anti-diabetic drugs we use in many non-diabetic states. Let us see that. This includes the PCOD. We use metformin and pio. They are all in a non-diabetic. NASH, pio, metformin, and SGLT2. And even the data with the dulaglutide now are also available. GLP-1 analogs. CHF, we have got a SGLT2 inhibitor, and we have got a DAPA heart failure study even in a non-diabetic. Obesity, we use GLP-1 and SGLT2. CKD, we use an SGLT2, and even in a non-diabetic CKD, we use the SGLT2 that is in diamond, and lipodystrophy, we use pioglitazone. This is another small study from our center. This is a change in status score with pioglitazone in non-diabetic patients with NASH. There was a significant decrease in status score as well as in liver injury score. And this study from our center, this is with the metformin, and we also show the decrease in enzymes, particularly alkaline phosphatase, and there was no change in BMI in these. So you have some effect of metformin, however, it is not as good as pioglitazone. So to conclude, the paradoxes in diabetes are encountered in day-to-day clinical practice. We also see many things in examination and management. I think physicians should be aware of these oddities to avoid clinical errors. Thank you. Thank you for your patience hearing.
Thank you, sir, for your excellent deliberation on paradoxes, making it very crystal clear. Now over to Dr. Ashok Kumar Das, sir, for your discussion. Since there are hardly any questions on the chat box, I request you to take over the questions.
Thank you,
Both the speakers
Sangramji.
and Jargar.
Sangram, thank you very much. And I'm delighted to be here. And then Anil, it was superb. You know, simple things you raised to a standard of discussion was very high. And it's great. And you know, I really think that it is absolutely original. And it shows your depth, diving deep into the problem and looking at it. Thank you. I just heard when I came to Chandigarh regarding your data on the pre-diabetes and HbA1c. Remember, Anil? And you know, today I saw the whole data. Thank you very much. And I will first go to Professor Shesha. I'll give it to Dr. Jargar to ask questions after that to you, and then I'll join the topic. Now, I must tell you, sir, Professor Shesha has been hailed as the father of GDM. That the way you presented today has shown that your involvement and your Anil, shall you stop sharing your slides now? Can you stop sharing your slides? Yeah. So the beauty is that we heard somebody who is the authority regarding the diabetes and pregnancy, hypertension pregnancy, a wonderful exposition from the starting of pregnancy till the childbirth and the child becoming diabetic. And also you have given very simple guidelines. As you rightly said, the greatest truths in the world are the simplest. And the guideline that you gave was very simple to show to us that how we can diagnose GDM by very simple way in a country which is very large with a lot of problems. So I'll just come to very quick questions before I hand over to Dr. Jargar. May I just start asking you that you emphasize on the transgenerational transmission. Am I correct, sir? You emphasize on the transgenerational transmission of the GDM and said that if we control diabetes early, it will be a great way to prevent diabetes. And that is great. That is absolutely great. Sir, you also hinted at the concept of the pregnancy clinic to diagnose any hyperglycemia in the first 12 weeks, which will really make a great change in the offspring and a great achievement for the country. I wanted to ask you, sir, how successful is this concept of pre-pregnancy clinic or the concept of fit to be mom? Now the obstetricians are saying today, every lady must be ready and fit to be mom. Sir, so we have gone through the stages where people conceive without the knowledge, deliver, again conceive during lactation without the knowledge. Jargar, am I correct? So how to become, and then what we should do is very important, sir. How we can sell this concept of pre-pregnancy clinic and this fit to be mom concept. Is by the obstetricians or we have a role, sir?
No, only obstetricians, because when woman conceives or when she gets married, she wants to know whether what will happen to her pregnancy. So they always go to her, not to me.
Yes,
sir. So exactly. Women should be able to obstetrician. They are the what you call all the flag for this DIP clinic, diabetes pregnancy clinic. I think it has to be done. One. Second thing, as I told you, unfortunately, health is not the central government's program. It's always state program. Unless states take the responsibility, it's very difficult to implement whatever I am talking, whatever you are going to talk now. So we are almost at a movement here. Gujarat is going to take up, Orissa is going to take up, Madras, Chennai already taken up the pregnancy mandatory to screen. So if it is done like that, probably we can. Otherwise, it's going to be impossible to control diabetes. No other way. Your walk, you do anything, as Bansal told, confusion will be there, both and diagnosed everywhere. So unless we unite together and sit and come with the guidelines which is possible, I think I sometimes feel dejected. Working for 40 years, 1980 onwards, still I am not able to see what I want to happen. Still,
I can understand your agony, sir. But I was hastened to add, sir, it has been also accepted by the Delhi government. I have seen the Delhi government issuing the circular, and also the acceptance by the central government and bringing out the only manual, the yellow book which you showed, is also
Yeah.
testimony to the fact it has been accepted. So the other thing I wanted to ask you that you did mention about the transgenetic epigenetic inheritance, transgenerational
Yeah, yeah.
epigenetic inheritance. So would you dilate on that epigenetic inheritance also?
See, there are two concepts. One is genetic, one epigenetic. Genetic, it's always transmitted from father, mother, whatever is there. Most important epigenetic. Epigenetic is 2-year, intrauterine and extrauterine. So the both can play a vital role in spite of genetic may be there, but intrauterine milieu, that's what I was telling about the growth of the fetus, maternal nutrition, all this will affect the development of fetus. Okay, child is born, still you must be very careful because post-delivery, the child should not gain weight. They must take the as what they call lifestyle modification, very important. So this epigenetic phenomena is controllable, genetic you can't control. So this is where we can. The only thing will be here. Epigenetic will be intrauterine programming, control the sugar of the mother, glucose well. Probably the one step practice we can succeed.
Absolutely. Sir, I've got a very important question to ask you. Sir, the fact that the DIPSI method of diagnostic criteria is simplest was also evident in the recent corona times. You remember that some articles were published?
Yeah.
Could you dilate on that, sir?
See, now it's so difficult now for the woman to come and wait for you in the clinic.
For the three tests. For the 3 tests.
Yeah.
Yes, sir.
See, there's a very simple method. It is one test. See whether she comes to the antenatal clinic or she at home, she can do the fasting. I have no objection that they can do it. But unfortunately, I think I will ask Dr. Jargar, our population, Indian population, or South Asian population, insulin resistance is very high. Number of papers have shown compared to Caucasians, our insulin is very high. So that we can diagnose some amount of GDM in the fasting, but not totally. As I told you in the slide, 71% in the American population, only 24% by the Indian population. So where is the question of depending only on fasting? Not possible. So best thing is to do either in the moment of the fasting and non-fasting, whatever may be there, then give a glucose, then do the one test. So it is a sure test. And I also told 140 is the hallmark of diagnosis of pregnancy because a number of studies have shown you both in the physiology and epidemiology how 140 is going to be the important figure. And I read one article just 2 days ago. JIMA, some Indian has published, one Swaminathan from Canada. I don't know where he got it. He said random blood 200 milligrams. He said he diagnosed as 200 milligram and above. So as I was told, I wrote a letter or article in the copy. When are we going to settle the diagnostic criteria of GDM? When are we going to settle diagnosis of GDM? If this is going to go happen, and what is Caucasian, which is not applicable in our ethnic population, and one good thing I like this white guys, they're telling, sir, we were doing it for ourselves. Why the hell you want to follow us?
Yes, sir. I think, sir, it is like a feast. We have got a diagnostic criteria. It has been tested. It has been mandatory testing has been also ordered by the few state governments. We are trying for Odisha and Gujarat, and also this test has stood the test of time, showing its impact on the child, impact on the pregnancy outcome, impact on the fetus. I think the study of your 11,000 ladies who delivered the child, the fetus through the adulthood are being monitored. So they will also show the tenacity of purpose. I wanted to ask you one more thing. You said that also it's important to have euglycemia during control, during the pregnancy period. And we heard about insulin. But sir, how do you think metformin meets up to this expectation of being used during GDM and pregnancy? Metformin, because I'm sure many obstetricians, many clinicians in the crowd will have this question. I want to ask you, how do you put metformin as a treatment choice for GDM and diabetes pregnancy?
I have no objection. I think I recommend insulin. There's no problem at all. But allowing the woman to go without treatment just because she doesn't want insulin, there's nothing wrong in metformin because most of our obstetricians allow them to take metformin because So far, a number of publications I've seen, including we are using metformin, we never had any problem on the pregnancy. But they say of 9 years, people gain weight, so many things that, see, we should be able to control sugar well. And then worrying about so many things, I don't think it's worth it. So our Oxford colleagues, definitely they will give metformin. There are papers out there, I don't deny that. Oh, see, I asked now, even now, that Institute of Obstetrics director, they said, once they start metformin for PCOS, they never stop.
Yes, they continue.
You stop. I don't know why that fellow says, why we feel we continue it, and they will never had any problem in our population. None of the obstetricians stop it, they always continue it.
Yeah, I think you are correct, sir. When PCOS becomes pregnant, the drug is continued and there was no side effect, and that was one of the testimony to the fact that metformin can be used. Maybe we advocate, if we are doing it consciously, give it up to
Now
12.
I want to ask my friend Dargar and Anil Bansal, why the ADA says stop it after conceiving or PCOS control in women case. What is the reason? They don't give the reason. They say stop. Why?
Anil, I think I saw your hand going up. You have to unmute yourself, Anil. Unmute yourself. You have to unmute yourself.
Well, I think we have enormous evidences for now metformin and its use in GD. And
repeat again. Anil, please say it again.
We have enormous evidences for use of metformin in GD. And now even the follow-up data of metformin treated mother and these children have followed even for a period of 9 years. I don't think metformin is a second thought in using in patients with GD. It should be used. And yes. Well, one of the most studies for many patients means at least some they also did require, in addition to metformin, they also required insulin. But I will say that 50% of the women can be prevented.
I think Anil, you have to speak to the mic. We understood you said that people you need lot of insulin can combine with metformin. Metformin plus insulin also good combination. But your voice is breaking. You speak into the mic, Anil, if you don't mind, please.
Okay.
Because your words are very precious. We don't want to miss it, Anil.
I just wanted to tell that we have enormous data one with the metformin.
Yes, that you said on the metformin in GDM and pregnancy. You also said it can be used alone or in combination when the insulin dose is very high.
I think the best is the people who use. In fact, if you use alone, then almost the 50% of the women they do require the concurrent use of insulin also. So what I mean to say is that 50% of the women can be controlled even with the metformin up to 8 doses of 2 grams. And yes, order whatever they
up to 2 grams. Maximum dose is 2 grams. We agree with that.
Or whatever they could.
Yeah. Now, Anil is here. I want to ask a question to Anil.
Yeah.
You know, there was a paper from Harness Medical Sciences, I forget her name. She started using, and Jargon also can clarify, they can use metformin from 12th week onwards. Whereas some people say start only 24th week. I don't know what is the reason. But good result. Mishra, I think.
So the recommendations after 12 weeks. Let Anil and Jargar clarify.
Yeah.
So I will just make one point here is that, sir, a woman with a polycystic ovarian disease.
Yeah, we do it in early pregnancy.
Who are preconceptionally receiving metformin, they were continuing metformin even during.
Yes.
Did not have any hazardous event or any unwanted event. The point here was that there were 2 points which were, I think initially it was thought that the metformin can prevent abortion. I think later on the study found that the metformin could not prevent the abortion, particularly in a woman who were previously known as a PCOS and they were receiving that. The advantage of that, they changed the guideline and the guideline became changed to that the metformin should be discontinued. If they are receiving preconceptionally, it should be discontinued because there was no benefit in it. As far as a fetal wastage was concerned. So that was the reason for that.
But Anil, I'll hasten to add, there are some studies which have shown that metformin is embryo protective. And you know, there are some studies, in so much so that few obstetricians like Hema Divakar, they say, why to deny a lady for this protection? I'm just wanted to...
I don't deny, because there are studies in favor of that a metformin is preventing the fetal wastage. But later on, some studies mentioned.
Okay, so it's controversial. I get your point. I get your point. Yeah. Dr. Jargar, your point, sir. Your
It was also shown with that metformin, even women receiving polycystic ovarian disease and pre-conceiving metformin, even the GDM could not be treated. So that's why they said the two beneficial effects which you wanted to have with the metformin is that the those who are destined to become a GDM, they will develop GDM even on metformin. So that I told you that 50% of the women may require not only metformin,
metformin plus insulin.
So what I mean to say now, this is a conclusion of my all this conversation is that I think metformin can be used safely. Only thing which people have demonstrated is the children, the born to the metformin mother, at the age of around 8 to 9 years, they are having a full metabolism.
We are not followed up in India. See, again, Anil, you have got a big hospital.
Yes, it is not in India.
Is it a fact?
Data from the Western population, they have
Yeah, this is not our population.
metabolic syndrome in
We are different, we are different.
those who are of 8 to 9 years of age. And even that have also been attributed to more environmental influences rather than the epigenetic alterations which has happened with the use of metformin during pregnancy. So what I will say that if you make a diagnosis of GDM and start with a lifestyle modification and metformin to begin with, try it for 2 weeks. If you are able to achieve the aim of the glucose control, that your fasting is around 90 and your post prandial 1 hour is less than 140. So I think there is nothing wrong in using metformin, and I think if you are using already in a second trimester.
Yes. Yes, sir. No, not yet. I'll get back to you in 10 minutes, sir. I'm coming back to you. Yeah, I think have Dr. Jargar's point of view, sir. Anything extra?
Dr. Shreya, we have been using metformin, Dr. Bansali, for almost 3 decades in GD. And we have not had any problems with it. In endocrinology, we see a lot of ladies with polycystic ovarian syndrome. And almost, if we see polycystic ovarian syndrome and a lady comes for a fertility issue, almost 1/3 of people do conceive just on metformin and then they continue it. The data shows if they prematurely stop it, the chances of miscarriages are more. PCOD.
Fetal.
And then they continued, and again, we have a huge data on that not happening, anything happening. In fact, sir, I was a part of a discussion group in UK diabetes 3 years back. And the consensus, the British consensus was that if they have a fertility issue in an obese individual, whatever the cause, if an obese individual gets pregnant, normally pregnant, they routinely use metformin to produce insulin resistance. They recommend it from day one, and they say we have no qualms about using this. So I think probably now the discussion should get over. Very few people are still reluctant, but I think metformin has been around for 3/4 of a century, and we have maximum experience with the molecule in the Indian subcontinent because it never was banned here. So nothing major has happened with it, and we know its collateral benefits are so huge. Number 2, sir, ever since we started talking about this 1-point blood sugar, I must tell you, sir, at least in the Valley of Kashmir, literally every lady gets her thyroid function test done and blood sugar done before she goes to any doctor now, when she gets pregnant.
Very good.
And thirdly, starting from the hospital I was working till now, always do a random blood sugar on a pregnant lady whenever she comes. It has 3 benefits. One, if it is more than 140, we start treatment and then follow the guidelines. Do this, do that. If it is less than 100, we are comfortable. We ask again next time do fasting, PP, and whatever GTT. If it is less than that, less than 100, ask again, be comfortable, get these tests done subsequently. And we have realized that almost 75 to 80% people we are comfortable, they don't have GDM. So at least we exclude that in them. And rest we get a little more aggressive, either with management or with further diagnosis. So this 1-point test has quite a useful tool, at least in segregating people and sort of regimenting people for future course of action during their pregnancy. As very aptly said right in the beginning by Professor Sashaya, when we are talking about a gestation diabetes, we are not only talking about that individual, we are talking probably about what is going to happen after gestation to her. We know now there are very high chances of her having diabetes, so we need to take care of it. And now she's a sort of so she becomes a focus group where we need to intervene for prevention. Secondly, the fetus, if it's a fetus, higher chance of having insulin resistance. And if it's a female fetus, the chance of transmitting into the next generation. This becomes extremely important for a population like India. Just in 1997, we had a diabetic population of 1.9 crore people. Today, we have 7 crore people. There's something grossly wrong with us apart from what is happening to the environment. So this is one of the factors that we need to keep in mind, minimizing those blood sugar levels and insulin resistance during that pregnancy to put some semblance of breaks. It's more than an epidemic in our country.
Thank you very much, sir. What you said is absolutely truth, Professor Seshaya, sir. I mean, there are two ways of preventing diabetes. Number one, for a country like India, universal screening is a must. That will give us the key to diagnose and intervene. And if it's a lady child, she will give it to her lady child, the transgender transmission which can be prevented. The second point that we have in our armamentarium today, the tools like Anil said, easier tools like Jargar said, easier tools like metformin and also insulins, and including analogs a little better in pregnancy than the. I mean that is a debatable question. We have both metformin and insulin in addition to nutritional therapy, which can control in about 67-70% of cases the hyperglycemia in a pregnant GDM lady. Therefore, we can ultimately establish euglycemia and prevent it. Sir, the criteria which Dipsy gave, which you pioneered, has been accepted by WHO, also has been accepted by the FIGO, has also been accepted by many other societies, so nice society. So we are nearing, accepted by the IDF. So I think, sir, the thing that you dreamt of, it is going to be fulfilled. And the criteria has been well established today. We all follow it, people follow it. And sir, it's a big country. People have their own choice to follow whatever criteria they find useful. But the simplest and the greatest, the ideas are the ones which can be easily done for the masses, which can really produce a great change in the destiny of the hyperglycemia in pregnancy. Thank you very much, sir. Thank you very much.
Sir, I have one question.
Yeah, Dr. Alcid, sir. Alcid is my colleague. Now he's the professor. He is my co-examiner. Alcid, please. Please, sir.
Thank you, sir. Thank you. At the outset, let me congratulate all the speakers and moderator Dr. Das and Jargar for this wonderful program we had. I have one question two questions for Dr. Seshaya. How frequently you should test, sir? Means first trimester, it is less than 140, negative. Again, second trimester, third, or every visit, antenatal checkup, they should come, we should test. That is one question. Second question is, the patients, that is women who are reluctant to take insulin and any other drug other than metformin, like SGLT inhibitors, any other drugs? Any other?
No.
There's two questions, sir.
I understand. See, personally, I feel the moment she conceives, she misses a period, 6th to 8th, 9th week, before that, she must consult. If it is a different matter. Now, at least first trimester, less than 15th week or 16th week, one test must be done.
Yeah.
If it is negative, go for second trimester, third trimester. Again, if we have seen people that week also they develop glucose tolerance. So it is extreme, but at least first, second trimester. What Government of India says is the Minister of Health, first visit woman comes, you do the test. If it is okay, leave her like that. Again, 24th, 28th week. 2 times they want to do the test. So this is one way. At least we will follow some government guidelines that we are safe and there. And then there's no other drug, as Dr. Jargar was telling, all of us feeding, and then Anil Bansal was telling, we use, if not insulin not possible, only drug we have tried is metformin, no other drug we have used, none of the drug are able to prove anywhere publication. That one or two articles came with acarbose, but we cannot use it, we are not sure about that. So let us stick to only one, at least metformin.
Yes, brilliant answer, sir. Lange said about the sulfonylureas, but they have not stood the test of time. Only drug that is Alcetis, sir, you know it, is the metformin which is used. Now, thank you very much, sir. A great talk. Thank you very much.
Thank you, sir.
We'll pass on to Dr. Anil, Professor Jargar. Anil, is Anil there?
I think connectivity issue is there.
No, he'll be back. I think he'll be back. So if Anil, are you there?
No point.
Sir, Professor Biradar will like to make a phone call to him if he's available. Sangramji?
Yes, sir. I am trying. Meantime, Dr. Jargar will take, sir.
Yeah, Jargar will take. You take the question. Jargar, how do you like the idea of that? I like the idea that the weight gain is an indication of longevity in a diabetic.
You know, Professor Das, there has been always a concept of healthy fat and unhealthy fat.
Yes.
We've always been talking about it for a long time.
Yes.
But in totality, you know, in endocrinology and diabetology, we every time talk about an ideal body weight. Becoming a skeleton does not give you any advantage. But if you look from the epidemiological point of view, obesity will do more harm than good. You know, we were just now talking about the epidemics of obesity. If you see, there's a global group known as NCD Collaboration Group.
Yes.
This is being coordinated from the Harvard Medical School and Imperial College London. And we have been a part of this for more than a decade. We published a paper in 2016 May issue of Lancet. We showed that in 1975, India, men and women were at position number 19 in terms of total quantum of obesity. And by the year 2014, Indian men who were at position number 19 had become number 5 globally. And Indian women who were at position number 19 had become number 3. So this was more, and this is one component. The second component is that from 11 million diabetics in 1975, we have become 77 million diabetics. Coronary artery disease has doubled up from 2005 to 2015. So in epidemiological terms, if you look at it in totality, overall obesity will do more harm than good. But what benefits accrue in a small segment of population?
Yeah, we got. I think this one.
In another study, the same group showed, which was published in Lancet September 2018, that in youngsters, children, youngsters and adolescents, in last half a century, obesity has increased tenfold. So you can imagine, sir, Professor Seshaya, sir, in the coming decades, how much it will snowball into diabetes, dyslipidemia, other consequences of that metabolic syndrome, polycystic ovarian syndrome, gestation diabetes. It will not only be what you were just now alluding to, Professor, that juggernaut of gestation diabetes, fetus getting exposed, the female fetus giving rise to next generation. So there are more than one mechanisms in place for wrecking mankind in general and wrecking the subcontinent in particular because of the consequences of that obesity, because that metabolic takeoff point is at a much lower level of obesity and BMI for our population than in the Western population, as Professor Seshia was referring to earlier on.
I think brilliant answer. I think I my friend, one issue that a recent concept of cardiometabolic based dysglycemia. You must have seen the paper, cardiometabolic based chronic disease. There they have said, as you rightly said, there are two drivers of this disease. One of the entire chronic disease. It will be diabetes, hypertension, obesity, CVD, CAD, whatever. And they said two are dysglycemia and obesity. You're absolutely correct. And the dysglycemia obesity are also correlated to each other. And the dysglycemia can be controlled to a greater extent if we take care, what Professor Seshia has shown beautifully, and by other methods. I think beautifully said. Now, one great thing that came out of the Anil's lecture, which I like everyone to take home. I'm a great fan of pioglitazone. And it is from the antiquity. I prescribe, and beautifully he said the fact that pioglitazone is not bad if used properly. I mean, from the proactive study and from the other study, he quoted heavily to say that the pioglitazone can produce little bit of weight gain, but this weight gain is not where there's a bad cholesterol, good cholesterol. This weight gain is not bad. He also showed pioglitazone is cardioprotective, which we knew, and it has reiterates our faith, and also a cheap drug. And in spite of, I don't think we have many drugs, in spite of the drugs available, we have great difficulty in controlling when people do not take insulin. And pioglitazone comes to our help. I would like from Dr. Jargar a very, very brief two-line comment.
I must tell you, Professor Das and Professor Seshia and others, I have been one of the strongest advocates of pioglitazone for two reasons. One, that is the most powerful insulin sensitizer. The most powerful insulin sensitizer. Number two, it is the most cost-effective oral hypoglycemic available in the market.
Absolutely.
And number three, whatever you say, good and bad about managing diabetes, nobody can manage diabetes well unless he or she has money to do it.
Absolutely.
And that is why I fought tooth and nail with Health Ministry and Government of India when they banned it.
Yeah.
And I ensured it comes back in 6 weeks.
Absolutely. And it came back.
You know
and
that.
We're happy. Yeah. I
You
know the whole
that
story.
whole story.
We were there. Yeah. And also we found out in 7.5 also it works. It works quite well. And also today, when the vitamin E or metformin as the second or the third indicated drug, pioglitazone stands out today as the number one drug. GLP-1 injectable is not easily available. Last but one question to you is that, he referred to a fact that eGFR coming down and then becoming plateau is a paradox. And he referred to the SGLT2 to drive home this point. He was referring to RENAL trial, RENALL trial. So what's your comment on that? I mean, while we prescribe, say, I'll go to the molecule direct. While we prescribe, say, we were prescribing the canagliflozin in the CREDENCE trial. What is your take on that eGFR becoming little less and then becoming plateau?
It's very simple. All of us need to understand that when we see somebody's eGFR, let's say somebody's eGFR falls from 75 to 60, we start getting concerned.
Yes, exactly.
Somebody's 60 falls to 50, we start getting concerned. But it is not that at 50 the person will have an end-stage renal disease.
Yes, sir.
It is not that it would kill him, but it only tells us that the show of decline of renal function has started. And the way it came down from 90 to 75, 70 to 60, 60 to 50, if the same metabolic state continues, then from 50 to 25, it will not take a long time. That is what the scare is. But when you use an ACE inhibitor, when you use an SGLT2, in a person whose eGFR is 45 and it drops down to 42, or whose eGFR is 38, it drops down to 35. it drops to 35, but then stabilizes at that and slightly improves. And if you compare it with the control population, this will continue falling the way it had fallen from 60 to 50, 50 to 40, and this 38 would have dropped down to 28. But in this patient population, whether with ACE inhibitors, ARBs, or with SGLT inhibitors, it stabilizes at a relatively lower level, but further regression is for that steep fall gets flattered.
Yeah,
so
I
it
think
takes
that-
a much longer time to develop an end-stage renal disease. Our job fundamentally is to retard, reduce the chances of end-stage renal disease so that we have minimal chances of minimal need for renal replacement therapy, which becomes highly costly, either renal dialysis or a kidney transplant. So you will be able to reduce it into 40% of people. What else do you want?
Therefore, Dr. Jargar, we gave a slogan. We said, contraindicate the contraindications. We said, use metformin. Yeah, we said, use metformin because ultimately it does you good. The last question, because I must hand it over to Sangramji, because now it is 8:29, 1 minute more I have, because we started late, sir, 1 minute more. I must tell you that the other thing that you referred to that people would like to know is regarding the impact of hemoglobin and hemoglobinopathy on the HbA1c. I think there's a belt in India which Dr. Ahuja, my teacher, pointed out long back in his book Progress in Clinical Medicine regarding the hemoglobinopathic chain, the region in the country. But I'm told that today we have some better machines by the Roche and others which takes care of the hemoglobinopathy, and we had used that machine in the I7-INDAP study. But that is besides the point. Everybody does accept to it, but one has to be careful and also to careful about the anemia. Beautiful point he made. But I personally feel HbA1c is good. It is very good for monitoring. It is very good for knowing a clinical trial. It is choice to know where we are. I mean, it is the measure which will improve the quality of diabetes care. Only when you measure, we improve. But you see, for the diagnosis and for the day-to-day adjustment of the doses, it is the first thing and the postprandial. I think you agree with me, Dr. Jargar. So that is the bread and butter. Dear friends, it is 8:30 now. We had wonderful talks by Professor Chandelier, the authority on the insulin, and a great talk by the father of GDM in India, Dr. Sheshaya. You saw his passion, his work, his heart, soul, and mind in GDM, and how passionate he is to drive home the point that we Indians must have Indian solutions, must respect the value and the data that come from our country and try to implement it. The proof of pudding is eating it. And he also said, and also world today had recognized in the FIGO, in the WHO, in the NICE, in the IDF, that this is the drug, and various state government issuing the circulars, that the simple test, if you do not do the simple test, then you know you cannot prevent the epidemic of diabetes that's going to come. And last, Anil was great in highlighting. He's not well. He was cold. He was not well. Probably. Yeah, Anil has come back. Anil, come on. So your topic was discussed in your absence.
Anil, I had to bat for you.
Yeah.
Thank you.
Anil, I think the paradoxes are the ones through which we progress. Somebody said that husband-wife are paradoxes, but they stay together for life. There are so many things. So many things can be said about the paradoxes. So Anil, great talk. Maybe that since you have come back, I'll just ask you one thing. You say about the absent full foot pulses and the foot ulcer. Now, don't you accept that MAC, medial arterial calcinosis, which develop, which we pick up by X-ray and not by the ABI, is not? That's also a paradox. No, we have a very bounding pulse, but ultimately the target area gets much less blood supply. Anil, a very quick answer.
So answer about this question is that if you got a Monkey-Burg sclerosis, which is monkey, that is basically calcification in the tunica media, which is visible on the X-rays, and if you do ABI, it is always usually more than 1.2. So normally you have a triphagic flow, but if you have a Monkey-Burg sclerosis, the flow may be biphagic or monophagic. So even the pulses may be bounding, but the tissue delivery of the oxygen or tissue delivery of the blood will be reduced. So that's usually also one of the paradox that even in a monkey cirrhosis, you have got a compromised blood flow to the tissues, despite the pulses are bounding.
Yeah, and the last question, you did mention about the vascular protective vis-a-vis cardioprotective. Now, just 2 lines on that, because that point people should take back home. Because today diabetes care is not only glucocentric, it is also vascular centric and also integral management. So some take-home points from that issue that you highlighted.
So why did I segregate? Because if you analyze the beneficial effects of the currently available medications, including GLP-1, SGLT2 inhibitors, pioglitazone, and even metformin, if you talk about that, most of these drugs, they do have only SGLT2 inhibitors were distinct because they do have both cardioprotective means on myocardial or cardiac myocytes, as well as they were vascular protective. GLP-1 analogs in a leader trial, which is one of the most quoted trials. So you had a beneficial effect only in the 3-point MACE, but not in the heart failure.
Yeah, that you said very beautifully.
So that gives a food for thought to whether there is really a dichotomy or there is a segregation between the vascular and cardioprotective. So that's why I collected the data for pioglitazone. Then we found that the pioglitazone has got a detrimental effect on myocytes. But on a vascular protective, even on a coronary vasculature, it is protective.
In your absence, Jargar discussed that. Absolutely.
Use pioglitazone even in preventing the restenosis of the stents. So it is a one very, very well effective in a stroke. So I think even a pioglitazone is much more effective in a cerebral vasculature, even more than a coronary vasculature. But on myocardium, it's absolutely detrimental. So we always say NYHA more than 2.
Yeah.
So you have a
brilliant answer.
You have to dissect the effect of a drug, whether it is a vascular or cardio. But fortunately, SGLT2 inhibitor is both.
Thank you. Given a new concept, thank you very much, Professor Sangram. Kindly excuse us because we are here for the love of diabetes, and and love of my Professor Seshaya, Professor Chandalia, my good friend Anil, and my great friend Jargar the Great. You didn't, sir. He was the selection committee chairman for the PGI, for the AIMS, and for the Sanjay Gandhi. He was even today, he is the ethics committee chairman of 12, 14, I don't know how many bigger institute, and he has made his mark. Jargar, it is a better, I always feel like hope with you, and thank you, great. Anil, it was great. Long time. We talked at the beginning of the month, but it was great. I'll again talk to you tomorrow morning. Thank you very much, Anil. Sir, it was great to have you. Professor Seshaya, sir, was great. And also great to have Dr. Chandalia. And last but not the least, sir, I really enjoyed Sangram Biradar sir, the president of the API, sir. I am a API by strict follower. Dr. Murugesh, sir, my regards to you.
Thank you.
Dr. Alsetti, sir, and all the people who have joined here, the entire community, in large number who are here with us. We are grateful to you. On behalf of all the excellent speakers and me and Jargar, we convey from Anil, Professor Seshaya, Professor Chandalia, from Jargar and me, we convey our sincere thanks, gratitude, and sincere thanks, gratitude to Sangramji for having called us and made our day fulfilled. Thank you, Sangram. Over to you.
Diwali greetings to everyone.
Diwali greetings. Happy Diwali. Happy
Diwali. I thank Professor Ashok Kumar Das for kindly accepting our invitation to.
No. I enjoyed, sir. I enjoyed maximum.
For this wonderful moderation. Since at 8:30 also there are no questions in the chat box that clearly says that how the deliberations were delivered, how clear were the speakers. There was no time for any questions to be asked by the audience. So I once again thank all the faculties for accepting our invitation in spite of their busy schedule, sparing 2 hours in this festive season. I request Dr. Murugesh to say vote of thanks on behalf of API, MESAT and ACP India chapter for sparing all those valuable times.
Wow, sir, what a wonderful discussion. I'm really blessed to be a good listener among the gurus and pandits of the diabetes and endocrinology here. I love the talks and discussion. Thanks a lot. And I, on behalf of the MESAT and ACP chapter, and India chapter and API Gulbarga. I express my thanks to Dr. P. S. Shankar sir and Dr. Y.P. Munjar sir for inaugurating today's virtual meeting and giving an excellent inaugural address. I extend my thanks to Professor Ashok Kumar Das sir and Professor Abdul Hamid Jargar sir for moderating and conducting a wonderful panel discussion, and really we loved that, sir. And I'm grateful to the today's speaker for giving an excellent and very made easy discussion for us like physicians. And I extend my thanks to Professor H.S. Dandalia sir, Professor V. Sheshaya sir, and Professor Anil Bansali sir. And excellent organization by Dr. Sangram Biradar sir for this.
Absolutely, absolutely.
And we really love this, sir. And I thank all the participants who are involved in this today's virtual meeting. And again, I love to be involved in furthermore meeting like this. Thank you very much, everyone. Thank you. Thank you.
Thank you.
Thank you one and all for attending. And I also thank all the attendees who have joined from all over the country. I once again thank all our dear faculty.
Sir, I can see Dr. Chanaria, my friend. Chanaria has joined, sir. V. Chanaria has joined. I can see him. And many people have joined whom I know, sir. So I'm so happy.
Yes, sir.
Thank you.
Dr. Sangram.
Yes, sir.
When Dr. Das is the chairperson, it is like Aapki Adalat for all the other people. Aapki Adalat, you know, everyone else is khada in kachari. क्यों अनिल मैंने कहा दास साहब के सामने तो अदालत में खड़ा हो जाओ पूरे 3 घंटे हमें ही बजा दिया
बट आपका विराट कोहली का स्ट्राइक सर आपका स्ट्राइक्स जो है विराट कोहली को मार रहे
पूरा अदालत में सबको खड़ा करके रखा किसी के सवाल पूछने की जरूरत ही नहीं कम से कम 150 सवाल तो हमसे लोगों से पूछे Always a pleasure, Ashok. Honest to God.
Thank you,
sir. Wish all a safe and happy Deepavali. Thank you, Bansali sir.
Thank you, everybody, sir.
Thank you, Alcete sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you all. Thank you one and all for joining. We sign out for the today. Thank you, sir. Good night.
Thank you. Shall we leave the meeting? We leave the meeting,
yes,
sir. Thank you, sir. Thank you.